Ma'am, we can go live.
Okay. Good
1
afternoon.
minute, I have some problem with my PowerPoint. Just a minute. Let me.
If we are live, we can start, Shruti, on YouTube.
Sure. Good afternoon, everyone. I welcome you to the masterclass today. In today's engaging healthcare environment, providing efficient cure in a cost-effective manner is an urgent priority. There are complex conditions like Spina Bifida management, Wilm's tumor management, childhood obesity management, or neurofibromatosis management, wherein no one clinician is good enough to treat all the conditions in the child. Therefore, there is a need for the multidisciplinary group. So these multidisciplinary clinics that we have in SRCC have group of healthcare professionals who have cognitive and procedural expertise in different areas of care delivery and can efficiently manage complex medical conditions such as what we are going to discuss today. So we have different panel discussions from the different multidisciplinary clinics that we run in SRCC. The first one being management of what is a team approach in the comprehensive management of Wilm's tumor. I welcome the hemato-oncology team, the pediatric surgery team, radiology team, and pathology team to please take over and start the panel session today.
Good afternoon, everyone. My name is Dr. Ruchira Misra. I'm the senior consultant in the PHO division of the Pediatric Hemonc and BMT unit of SRCC Children's Hospital. So the next 1 hour will be dedicated to pediatric oncology and the role of multidisciplinary care in pediatric oncology. I would like to start off by asking our head of the department and chairman of the Oncology Collegium, Dr. Poorna Kurkure, to give us an overview of about what actually is a multidisciplinary team approach and how does it is needed in pediatric oncology, because this is one field where just having one person is not good enough. Dr. Kurkure, over to you, please.
Good afternoon, everyone. Can you hear me? Hello?
Yeah, we can hear you,
ma'am.
madam.
Yes, we can hear you, ma'am.
And you can I share the screen? Good afternoon and welcome to this master class. Very appropriately, it is in month of September that we are talking about childhood cancer, which whole month is celebrated as Childhood Cancer Awareness Month. And we are very pleased to have this masterclass on pediatric cancers during this month. So, can I share my screen, please? So, to emphasize the need for multidisciplinary, the impact, I would just start my, can I? So, as I said, September, can you see my screen, please?
Yes, ma'am, it's yet to start sharing, but I think it will start now.
Can you see now or not?
Yes, ma'am.
Ma'am, would you put it on slideshow, please?
Hmm.
Yeah.
So as I just said that September is a Childhood Cancer Awareness Month, and the slogan is Go Gold. Children are as precious as gold, and that is why we wear this golden ribbon and also support the cause of childhood cancer. So why we are talking about childhood cancer awareness, I will just touch upon that first. As we all know, early diagnosis is very imperative for effective therapy and improved survival rates. Failure to recognize symptoms and signs, coupled with reluctance to entertain possibility of a neoplastic process. This is very important because we don't want to entertain the diagnosis of cancer in children. And that is how we miss many a times what your mind knows, your eyes see. And that is why you can miss them. And not entertaining the possibility leads to the delayed diagnosis. Systematic clinical and investigational approach with an enlightened awareness would help in timely diagnosis. And that is why we all talk about childhood cancer awareness in this month. As we all know that large proportion of childhood cancers are now curable. And that is why we don't want to be starting with a negative attitude and pessimistic view, but we want to really go very hard and work on it for this improved survival rate. As we all know, the mortality in Indian children is still infection, low birth weight, congenital anomalies, accidents, and malignancy, but all others being preventable, that is infection, low birth weight, and particularly accidents. And with improved care, antenatal care, avoiding congenital anomalies is possible in today's time, and thus malignancy takes a priority in the current scenario as we improve in all other aspects. With population of almost 1.3 billion now, this was 1.25 billion in 2013, and 35% population falling in the pediatric age group of 0 to 14, and another additional 10% in 15 to 19 age group. If we extend the age limit to 18, there is a large proportion of this population in this age group, and thus the numbers are though the incidence is very low, the number is very high, and approximately 60% of new cancer cases in the pediatric age group are supposed to be diagnosed each year by the calculations. But we don't see that everyone reaches the cancer center and gets diagnosed and treated. That is a fact. There are certain different, we all say that children are not little adults, and there is a difference between childhood and adult cancer. As we can see here that childhood cancers are mainly the tissue involvement like hematopoietic, lymphatic, CNS, muscle, bone, while adult cancers are mainly involving the organs like breast, lung, colon. So they are more epithelial in origin. Malignancies are neuroectodermal and mesodermal in origin in children, and they are more plastic tissues, like more embryonal or blastic tissues that undergo this malignant transformation. And that is why they have a high potential of multiplication, and 80% of these cancers, childhood cancers, are considered as disseminated at diagnosis. And thus the medical management, that is chemotherapy, takes a very, very important and pivotal role as opposed to the local and regional therapy, which takes important role for adult tumors. Early detection mostly it is accidental, as opposed to the adult where we advocate screening and lifestyle changes for prevention, as well as we talk about early detection by regular screening. Such screening is not there for childhood cancer. And that is why it is the suspicion by the caretakers, by the parents, by the family physician, by the pediatricians, ultimately leads to the timely diagnosis and appropriate interventions. And the childhood cancers are mainly divided into two broad categories: hematological, which is leukemia, lymphomas, and solid tumors, which are commonly known are Wilm's tumors, neuroblastoma, rhabdomyosarcoma, etc. And the distinction between the two is very, very important. Hematological malignancies, they generally come very dramatically and may get escalated very fast. While solid tumors, many of them, they go silent for many, many days before they reach the diagnosis. And that is why, and in solid tumors, the children can end up with, besides family physician and pediatricians, a pediatric surgeon, orthopedic surgeon, rheumatologist, because they have a varied manifestation. I'm not going into the details of the clinical sign symptoms because I'm sure my colleagues will enlighten you on this in the subsequent panel discussions. But to say, hematological malignancies, generally they have a very dramatic presentations and they get escalated very quickly from family physician or pediatricians to a pediatric oncologist. While solid tumors, they go many a times round and round. And this is the distribution that generally is seen at all major cancer centers, that leukemia, lymphoma, they form half of the bulk, and remaining half, that is 50%, they are together as a solid tumors. And as you can see, there are many, many solid tumors, and the presentation can be to many physicians, like nervous system, CNS tumors can go to either a neurologist or a neurosurgeon. Retinoblastoma can go to ophthalmologist, so on and so forth. So here the coordination is very, very important. And that is how the symptoms and signs are generally due to consequence of, they have a very high propensity for mano involvement, and due to a mass effect, they can have a pressure effect and can present with various manifestation of the same. I will not go into the details because this will be elaborated further by my panelists. One thing which we have to remember is the child with a predisposition to malignancy. When a child goes to a family physician or a pediatrician for a well baby clinic and all, and if you have one of this, then you have to be on alert, and there are definite screening guidelines as to how one screens them and for how long they have to be screened for possibility of malignancies. So we won't go into the detail of that because it's a subject by itself. But most important point which we are trying to drive home today is the multidisciplinary approach. The multimodality approach and the correct chronology of delivery of the care is responsible for the improved survival in most instances. And this has been the backbone of success in pediatric oncology. Like pediatric joint clinics, neuro-oncology meetings, these are the dates which are applicable. When I was at Tata, long back they have been started, and that has been the backbone of the success. And all this multidisciplinary approach, you have a pediatric oncologist, radiation oncologist, surgeons, pathologists, radiologists, social worker, they all come together. And it has been very well said by Bushnell that the pride of the discipline has to be put aside. Who sees the patient first is not important, but coming together and working together ultimately leads to the success. And these are the basic principles. I will not go into that. And this cartoon tells you as to how how we have to integrate everyone into this system. That when you have a child who you have a suspicion of a cancer, has to undergo clinical evaluation, and then the investigations are done accordingly with the differential diagnosis in mind as to what is the probability in this particular case. And then once you have a diagnostic armament, all the parameters ready, then you review them into the joint clinic to reach to the final diagnosis. Sometimes you have a diagnostic dilemmas which will be illustrated subsequently in the panel discussion. You have an interaction with diagnostic services, that is mainly the pathologist and radiologist, and then ultimately the final diagnosis is reached. A therapeutic strategy is planned, whether who will do what at what time. There are three main modalities of treatment, that is chemotherapy, radiotherapy, and surgery. But in what chronology and at what stage who will chip in is decided into this joint clinic. Then the treatment is executed according to what has been planned. There is no ad hocism which is allowed. And then you reach the point of cessation of therapy. And further to that, you have to follow them up individually as your patient, and also whenever there is any new findings, again you discuss them in the joint clinic. And after 2 years of cessation of therapy, they are proclaimed as long-term survivor, and they can be followed up. They subsequently get followed up in after completion of therapy clinic. Because they are survivors, they have to be monitored for the late effects of therapy, which they had received as very young child. They have to be rehabilitated if there is a need of this kind. And this surveillance for late effects really teaches you a lot so as to avoid or minimize the late effects in future. If at any stage in follow-ups, there is a recurrence and you reach a point where active treatment stops to have a meaningful outcome, then they are directed for palliative therapy, which is also very, very important aspects in the care of a child with cancer. So you can see as to how the whole system has to work in coordination to achieve what we want to achieve. And as you can see in this pyramid, surgery, radiotherapy, and chemotherapy are at the top. They are the executors of or implementer of the therapy. But they have to be supported by so many other aspects: radiology, pathology, molecular biology. That is the first support that you need to get to the diagnosis. And down the line, the whole alliance with many NGOs, nutritional support, infection control support, all these are a part of the system to allow the implementers, that is the surgeons or a radiation oncologist or a medical oncologist, to give what is support or to execute the plan as required. So this is very, very important, that the top cannot do anything without the strong base that we have. And there is an equal importance of a shared care with the general practitioners, means the family physician or the pediatrician, that it starts with the early suspicion and diagnosis, and the child is being taken care of at pediatric cancer units with all the support that I just mentioned, and with the therapeutic alliance from the society which comes through NGOs. And then again the child is shared, the care is shared with the general practitioners or a family physicians for the continued care. So it is always said that it takes a village to treat a child with cancer. And this village is all of us who are involved in the care of the child. We all know that abdominal tumors are the commonest presentation, and that is why we have decided today to discuss the commonest solid tumors that are which present as abdominal tumors in today's panel. I now hand over the screen and the mic to our coordinator, Dr. Ruchira, to take the panel discussion further to illustrate certain points. At SRCC, because of all experience that we had, we started the multidisciplinary clinics right in the beginning as we started our services. That is in 2017-18. And today we have reached a point where many children have finished therapy and are joining the team of survivors. And we are soon going to start our late effect clinic also after completion of treatment clinic for the complete holistic care that I just illustrated. Thank you. Over to you, Dr. Ruchira.
Thank you so much, ma'am. Thank you for that very lucid introduction and sharing with us the importance of having a multidisciplinary team approach. What generally happens with any abdominal mass is that the child first presents to the general pediatrician, who then has a clinical suspicion for a leukemia or for a malignancy, and then decides that this child needs to be sent for further care to either oncologist or a pediatric surgeon or to radiologists or whosoever they think might be needed for the care of this patient. So what we would like to do today is to present to you and present it as a discussion, as a panel discussion, is the care that we offer to all our patients who come in as with an abdominal mass. And with that, we will start this presentation. What we have done for today's meeting is that we have kept the panel of all the teams that are involved in the care of the patient. So we have with us Dr. Rasiksha, who's the pediatric surgeon. A lot of times the cases are actually referred to him because they feel that this is an abdominal mass that needs to be operated urgently. And then he takes it up and calls for the MDT. Which will also involve not just the clinical people, so it will involve him as the pediatric surgeon and his team, which also involves the oncologist. You've already met Dr. Poona Kurkure, but we also have a team with Dr. Sujata Mushrif on board, who's a pediatric hematologist oncologist, who's the second member of the team, and I'm the third member of the team. But we cannot do without our lab support. So Dr. Khandalkar and Dr. Shefali Jadhav, who are our doctors in the lab, who look at the histopathology and give us an accurate diagnosis as well as a response assessment for these tumors. And without the support of our radiologists, who are the first point where we decide how to treat these patients, we would not be able to work. So I have with us Dr. Hiren Panwala today, and he, with his colleague Dr. Rajni Krishnan, also form the team that looks after the radiology for our patients. So what we will do is we will go through 4 cases to see how having all the 4 team members put in their efforts actually makes a difference. Dr. Kurkure has already spoken about the signs of cancer and the importance in recognizing and having a suspicion for cancer, so I won't go in detail about this. What I would like to share with you is the cases of abdominal masses or solid tumors that we have seen at SRCC over the last 2 years. We've seen about 174 patients with solid tumors. This is not including leukemias that we see, which are generally referred to as liquid tumors in our colloquial terms. Out of these, 85 have been abdominal masses, so almost 50% of these come in as abdominal masses, and 38 of these were renal masses at presentation itself. So we knew that this was a tumor that was arising from the kidney. How we went about diagnosing them and treating them is what the story will follow in the next 4 cases. I will begin with the first case. This is a 2.5-year-old child who presented with painless hematuria since the last 2 weeks. There was no history of fever or abdominal pain present. There was a history of similar hematuria happening 1 month ago, but that had recovered spontaneously, so the family had not done anything about it. They were on examination. There was no obvious dysmorphism present, but blood pressures were high, so she did have hypertension. Her developmental milestones were normal for age. When we did an examination, we found a soft, non-tender abdomen, but there was an abdominal mass palpable that was almost about 5 by 7 centimeters in size. Her genitals were normal. Initial lab investigations were normal, so there was no renal disturbance present or no pancytopenia present at all. She came with an ultrasound abdomen that had been done outside, which showed that there was a renal mass, and the pediatrician had then referred to the higher center, saying that this is a malignancy and needs more care than this. So at our institute, we then followed it up with a CT chest, abdomen, and pelvis, which Dr. Hiren, can I ask you to go through the slides and explain what you found in those images? And then we followed that up with a core biopsy for this mass. Dr. Hiren, could you go through the slides to educate us as to what a pediatrician should be looking at when they see that there is a renal mass?
Yeah, so these are the CT scan axial images at the area of interest, and you can see that the left kidney shows this kind of round-looking heterogeneously enhancing mass lesion, which is very well seen on the last image on the right side.
Yeah.
So that's the mass.
Yeah.
And you can see that it is also involving into the renal pelvis on the top of the image. You can see that. So that is very important on imaging aspect, that we have to tell to the surgeon or clinician that is there any invasion of the renal pelvis or not, because that upstage the staging for that tumor. And when we see this kind of heterogeneously enhancing mass which is arising from kidney, and in this kind of age group, most likely will be a Wilm's tumor. There are certain differentials that we'll be seeing in the subsequent slides. But in that same aspect, you have to see that is there any involvement of renal vein? Is there any tumor extending into the renal vein, which is seen on the first image? But here the left renal vein is normally opacifying, so there is not obvious thrombosis in the renal vein. But these are a few of the area that you have to take care. You also look for locoregional adenopathy, like near the renal hilum or para-aortic region. We have to be carefully about the nodes. And then, of course, you have to see for the distant metastasis in lung, liver. These are the common sites. So in this patient, as you can see on the first image axial, the arrow is pointing towards an enlarged node, which is located near the left renal hilum. And size-wise, it is more than 1 centimeter. And here on this reconstructed sagittal images, we can see that the lesion tumor is involving the renal pelvis, as ma'am is showing by the arrows, and it is causing this kind of upstream hydronephrosis. So you are seeing some darker grayish kind of appearance, that is the calyceal dilatation because of the tumor extending into the renal pelvis. And you are seeing some white tubular kind of thing, that is the contrast excretion into the rest of the ureter. So the lesion was involving the pelvic ureteric junction, but rest of the ureter was like normally opacing with the contrast. So these are the information we should give. And here, these are the other reconstructed view, which shows that the tumor is involving the anterior cortex or posterior cortex, and how much amount of the kidney is involved by the tumor. So that is very important. Either partial resection is possible, or we need to remove the entire kidney. This kind of information we have to give to the surgeon. Here we can see on the last image that it involves the anterior as well as posterior cortex both, and it's involving predominantly the lower pole and with some extension into the mid pole area also. The upper pole is spared in this lesion.
So radiologically, what would be your staging for this patient?
So we are seeing that there is invasion of the pelvic ureteric junction as well as lymph nodes are enlarged. So that will give up to at least stage 3 of the disease, according to imaging wise.
Yeah. So when we see a renal mass, the first we'd ask for imaging to be done for this patient, and on the imaging we had now called her a stage 3 renal mass, which was probably a Wilm's tumor. We asked for a core biopsy in this patient, and Dr. Shefali and Dr. Khandalkar, could you guide us as to what you found in the biopsy, and could we clinch a diagnosis on the core biopsy itself?
Yes, ma'am. Ma'am, as you can see, this is a low power view and this is an high power view. In the low power view, you can see some small round blue colored cells which are arranged in sheets. These are arranged in tubules, which is the epithelial component, and these are also arranged in stromal part, mesenchymal element, which is suggestive of a triphasic Wilm's tumor.
They're just even in tight clusters. That is the
Blastomal component.
So all three components can be seen in this particular.
This particular tumor represents all three components, and hence it is called as a triphasic tumor, Wilm's tumor, or a nephroblastoma.
So based just on the renal imaging as well as the core biopsy, we had a histopathological diagnosis of a Wilm's tumor, and on the staging we were calling it a stage 3 regimen. Dr. Sujata Mushrif, my question to you is, how do you treat a stage 3 and how do you prognosticate care for this patient?
So a stage 3 tumor usually will need 3 drugs, what we say, instead of 2 drugs, like which before the surgery will give only 2 drugs, because we assess the treatment response based on the 2 drugs, and then we add a 3rd drug if it indeed is a stage 3. And if it is truly a stage 3, then that ideally needs radiation to that abdominal area as well as the loin too.
So stage 3 means disease that has loco-regional spread but has not metastasized to other areas of the body. We initially start off with a 2-drug regimen. There are 2 protocols that are generally followed. One is the SIOP protocol and one is the American protocol, which is also called the NWTS protocol, where you have upfront surgery involved in these patients. So we elected to use the SIOP protocol, where we gave chemotherapy first because we believed that this was a large tumor and it needed to be shrunk before we could take up for surgery. Dr. Rasiksha, can I ask you, because a lot of patients get referred to you first with a renal mass, what are the patients where you would like to do upfront nephrectomy, and which cases would you like to actually offer them chemotherapy first and then take up for surgery later on?
So here, what I would say that, like what you said in, we have NWTS or American staging protocol where they do upfront surgery. Being trained in USA, we were doing all upfront surgery. But in India, there are a lot of patients who comes in advanced stage of disease. And then we decide, depending upon the stage of the disease, whether we want to do upfront surgery or give chemo. So if the mass is extending onto the crossing the midline, then we will like to give chemo. If mass is extending into the renal vein, IVC, and going up to the atrium, then we will like to give chemo. If it is stage 3 and above, infiltrating the tissues, then we will like to give chemo. If there are lymph nodes which are involved, then we will give upfront chemo and then do the surgery. So these are some of the indications which we have by convention have decided to give chemo and then go ahead with surgery.
So this is how the multidisciplinary team helped us. So this patient was first referred to Dr. Shah, but then eventually we started the treatment first, gave 4 weeks of chemotherapy, followed that up with surgery where a left nephrectomy was done. And there was also sampling of the left hilar and left infrahilar lymph nodes was done as well. Dr. Shefali, could you go through the slides again with us to see the response? Was there a response to the chemotherapy or not?
Ruchira, I like to say another thing here. Because of the chemo, the tumor shrunk so much, we could do it laparoscopically also. So this case we did laparoscopic
surgery was done
with lymph node sampling. And another interesting finding was this child had duplex kidney. So on imaging, you can see the upper pole, which was not hydronephrotic, but the lower pole was hydronephrotic and harboring the Wilm's tumor. And of course, we took out the entire kidney. Yeah, please go ahead.
Yes, sir. Thank you, sir. So we received a left nephrectomy specimen measuring around 9 centimeter. The renal capsule was intact. As you can see at the upper part, the tumor was there measuring 4 centimeter in diameter. Along with that, we also received infrahilar para-aortic, infrahilar para-aortocaval lymph nodes. For the gross, we generally fix the tumor for a day, and the next day we take a grid section along with sections from the renal pelvis, the cut margins from the ureters, the vessel, and the perirenal fat is also be taken. It's important for sampling and to suggest any tumor are there in histopath. So for that we require a grid section and along with other things. So as you can see, there are these hordes of multiple slides and each one are named accordingly as per. Ma'am, could you do next? So on microscopy, this tumor was basically was more than 1/3 was viable and more than 2/3 was a stromal component, and a very small focus of blastomal was there, as you can see, and other things, the vascular resection margin, renal sinus were all free from tumor. The uretric sections were also free from tumor. All nodes were negative, and hence as per the SIOP classification, the diagnosis was intermediate risk nephroblastoma, stromal type.
But because we had been able to take out the tumor completely and there was no loco-regional spread present because of the lymph node sampling, we could now stage it as a stage 1. Dr. Sujata, now that we can downstage it, does that mean that we can offer them lesser chemotherapy at this stage?
Definitely so. So there is a good response as well as there is a restaging that we have done surgically now. So our initial staging, often the lymph nodes can be just reactive lymph nodes, which do not show the evidence of malignancy when on histopath. So we have downstaged this to stage 1, which reduces the treatment to a much lesser degree.
And also what we
and of course doesn't need radiation as otherwise
as we had initially thought she might need. So the pre-surgery chemotherapy for all stage 1 to stage 4 is the same. So that really doesn't make a difference whether you were stage 1 initially or a stage 3 initially. If you were stage 4, yes, we would have had to add more drugs, but stage 1 to stage 3 all get the same pre-surgery chemotherapy. So that didn't make a difference. Now the post-surgery chemotherapy could actually be reduced because we had managed to get complete resection done in these cases.
And just to add on to her, that pre-surgery chemotherapy has to be same, because that on that basis is what we decide the response. So we can't change it, and
that there's a need for having a uniform protocol available for all cases. Sir, we mentioned about lymph node sampling. A lot of times when we get cases who come from outside where only a nephrectomy has been done, but no lymph node sampling has been done, does that actually affect the care of the patient? And what's the importance, which lymph nodes should be sampled when a pediatric surgeon is looking at a Wilm's tumor? Dr. Rasik?
Sorry, I missed it.
So the question to you is that we talked about lymph node sampling being done, and Shefali mentioned that the lymph nodes were all reactive and not involved with disease. We often find when pediatric surgeons operate the tumors outside and then refer after nephrectomy, a lot of times the lymph nodes have not been sampled. So what's the importance of lymph node sampling for Wilm's tumors, and which lymph nodes should be sampled in these patients?
Yeah, so lymph nodes, we like to take at least 5 sites, starting from hilar, then suprahilar, infrahilar, aortocaval, and iliac. And we send it. Now, depending upon if the lymph nodes are involved, then it upstages the disease from stage 2 to stage 3, and the chemo will be different. So it is very important to sample the lymph nodes. We don't do radical dissection, retroperitoneal radical dissection, but lymph nodes are sampled to know the exact histopathological staging of the disease.
So a take-home message from this case would be that all lymph nodes, any pediatric surgeon in the group should be looking at lymph node sampling. You don't need to take out all of them, but you need to sample all the relevant groups of this. What would you do if the lymph nodes were not sampled? If you got a case that came to you, but they had a nephrectomy and a good nephrectomy done, or a tumor removed, but the lymph nodes were not sampled.
In fact, we did have one patient who came to us after the nephrectomy for chemotherapy, and no lymph nodes were sampled. So we upstaged it to stage 3. We gave him the benefit of adding a 3rd drug, but we didn't give radiation, because even on CT scan prior to this thing, we didn't worry that there was an enlarged lymph node, but we didn't want to take a chance of a recurrence. So we did end up giving a third drug. So, and it makes sense because that third drug can have potential cardiotoxicity. So if at all, we would have liked to avoid it, but we had to give it because we didn't have lymph node sampling done.
There is a very good paper by Dr. Sajid Qureshi and his team from Tata Memorial Hospital, which actually tells us about the lymph node sampling, the importance, as well as which nodes to sample and how the treatment's been affected in the follow-up of those patients, where they've managed to do a good and proper surgery with these patients. So, as I said, this is the take-home message from this case, that although the patients may actually reach the surgeon first, sometimes chemotherapy may be the first treatment modality that we are offering because of an MDT approach to looking at the case as a whole. And whenever you're looking at surgery, you should ask for lymph node sampling and ask for representation of all the 5 groups that Sir has mentioned when you're looking, when you're doing the surgery, because this may have a potential to actually downstage the disease later on rather than upstage it, which we would err on side of upstaging them if the lymph node sampling was not done. So how do you stage a Wilm's tumor, Dr. Sujata?
So this is a busy slide to show, but I'll in simple terms tell the staging. So we'll go with stage 1 and stage 4 and then see at stage 2 and 3. So stage 1 is anything which is confined to the kidney, to inside the renal capsule or inside the tumor capsule. And stage 4 is anything that has left the abdominal compartment or the renal compartment and say gone to the lung, to the liver, to the bone, very rarely to the brain. So that becomes stage 4. And in Wilm's tumor, we also have a stage 5, wherein we see bilateral renal tumors in certain syndromic conditions and sometimes non-syndromic conditions too. We call it stage 5, but it is not necessarily worse than stage 4. The stage 5 individual side is staged according to the rest of the staging system. So individually, a left-sided bilateral can be a stage 1, and the right tumor can be stage 2, say. So that individual side has to be staged. Then stage 2 is something which is not limited to the renal capsule or to the tumor pseudocapsule. It is beyond that or invades that, but then it is surgically completely removed. Or it involves the renal sinus or the ureter or the IVC, but then it is completely resected and the margins are negative. Stage 3, say, we could only biopsy the tumor and not take it out because it was, say, non-resectable or very large, or it is something which is gone out to the peritoneum, or there is a tumor margin that is positive, resection margin that is positive. Or you can see clear deposits on the peritoneum, or there is a spontaneous tumor rupture that can often happen even before they come to us.
So just as a thing over here, a core biopsy or a needle biopsy actually doesn't make it a stage 3. If you use an open biopsy, that's what makes it a stage 3. So both NWTS, where they're actually doing an open resection, but even the UK protocols or the SIOP protocols, they say that you can do core biopsies if you want to get a diagnosis. But an open biopsy is something that nobody is recommending.
And it's a little overkill to do an open biopsy too. And the other thing is, to add on to her point, a needle biopsy when done in the SIOP approach is usually followed up with chemotherapy right away. That's why it doesn't upstage the tumor. And it has to be done in a posterior approach.
Because we have general pediatricians and you are the people seeing the patient first, whenever you're suspecting a Wilm's tumor, there are few images that imaging parameters that we would like you to do. So we ask for a chest X-ray, but rather than just asking for a chest X-ray, we would ask for a CT chest, abdomen and pelvis. So don't just ask for a CT abdomen, ask for a complete CT abdomen and pelvis, chest, abdomen and pelvis, because we want to look for lung metastases as well. A lot of people get an ultrasound done. That is fine because it helps us with the renal biopsy also, and it kind of gives you the first clinical suspicion as well. You could ask for an MRI, but again, if you're asking for the MRI, we want the chest to be included as well, because you have to look for lung metastasis. That's the commonest area that this will go into. Sometimes we may ask for a DMSA scan to assess the renal functions, or if we are really suspecting that this is not a Wilms and something else, then a bone scan may actually be asked as well. So in cases where you have a clear cell sarcoma or a rhabdoid tumor which may metastasize to the bones, those are indications where we would be asking for a bone scan. The reason why we would be asking for these imaging is to identify the origin of the tumor, that is actually renal in origin, assess the extent, like Dr. Hiren pointed out. We need to know exactly where all the tumor has gone, whether it's involving the renal vascular pedicle, lymph nodes, or is there any distant metastasis. And also every time we need to, even though it may be a unilateral mass at presentation, we really need to find out that it is not a bilateral Wilms tumor that we are actually dealing with. So Dr. Hiren, what are the other images that you see which kind of help you to stage as a stage 3? Can you just go through that? Because imaging is always something that we keep learning every time, new things.
Yeah, so the tumor can invade the adjacent organs. And this is the example of the right-sided Wilms tumor, which is arising from the kidney, and superiorly it is invading the liver parenchyma, especially the posterior segments of the right lobe. You can see that the tumor is directly invading. It's not like distant metastasis. It is directly invading, and the liver parenchyma in the segment 7 or 6 of the right lobe. So that is one of the criteria why how it upstages the tumor. Then can we go to the next slide? Then if the tumor ruptures in the surrounding, that is also it ruptures into peritoneal spaces, then it upstages the tumor, and it goes into the stage 3. For criteria to say that tumor has ruptured, the free fluid should be having high density. Only minimal free fluid, which is having almost near to the water density or bladder density, lumen density, that doesn't qualify it for rupture, but it need to be very high density, and it should be surrounding the tumor area to be confident enough that to tell that this is looking like more of a tumor rupture and that stage is disease. So this is the example of heterogeneous density in that perinephric and retroperitoneal area, and it was looking like tumor rupture because the HU value was very high. So this is another example in which we can say that the tumor is upstaged. When we see the tumor thrombus, it is extending into the IVC, and here we can see the entire intrahepatic part of the IVC, and it also extends into the right atrium. So when we see this kind of thing, that also is very important, and this can be done by CT scan as well as MRI. And just to make one point, when you are doing MRI, for evaluating lung metastasis, you always have to do CT only, because MRI is not that much sensitive to pick up less than 1 centimeter nodules. So even though you are doing MRI for the abdomen, you have to do CT chest separately and preferably contrast enhanced. Yeah.
So it has to be a contrast enhanced CT scan of the chest.
Yeah, it has to be contrast enhanced CT scan.
Is Dr. Hiren, MRI is more helpful when you have a bilateral renal tumors than the unilateral, because in unilateral Wilms tumor, we are more concerned about the epicenter and the extent of disease, etc., which are well delineated. Anatomy is always well delineated by a CT scan, while in a bilateral renal tumors, I would say, which are picked up on ultrasound, MRI can be of a help, because there are many conditions which can be bilateral, and MRI deals with more of a pathological aspects of the lesions and guides you further.
Yes.
Is it true or not?
Yeah, it is to a certain extent. It is true, because sometimes MRI may add extra value when we are assessing bilateral renal tumor. Then we are worried that those lesions which are seeing on MRI or CT, whether those are only nephrogenic rest or they are real Wilms tumor. So in that kind of scenario, MRI may add in value. And MRI has some certain sequences like diffusion weighted sequences, and it can pick up hemorrhage also with confidence, which CT may or may not pick up. So while assessing diffusion weighted images, we can say that this is looking like more of a malignant condition, or this is more like a benign condition. So there are certain aspects of the MRI. Yeah, of course, it has got very high soft tissue resolution, so we can see some tiny cystic changes also within the lesion. Sometimes even the cyst also can confuse as a solid nephrogenic rest or Wilms tumor on CT. So in certain aspect, MRI will help, and it is slightly superior to the CT. So we can use it in bilateral Wilm's tumor, definitely, as a problem solving tool.
I cannot say that. So the radiologist becomes very important for us, but the histopathologist is equally important because our risk assessment is based on what the histopathologist reports to us. So Shefali, when you're looking at the histopathology, how are you doing to go to do a risk stratification for us in these patients? Yeah, you're on mute, Shefali.
Sorry. The risk stratification basically starts like if we get a whole hysterectomy specimen, we see whether the nephrectomy specimen, we see whether the tumor, where it has reached, whether it has gone to the capsule, the perinephric fat, gelatinous fascia. We see whether the renal sinuses are involved or not. We see whether intrarenal vessel or the vessels at the sinuses are involved or not. We see the amount of tumor. If it is a post chemotherapy, we see how much of the tumor is there, whether it is more than 1/3, whether it is more than 2/3. We see the blastomal component is there or not. We see whether it is focal or diffuse anaplasia, because both of them also have different stages, and as per they have different the chemotherapy up stages.
Yeah.
And yeah, that's it.
So this is a picture where we see anaplasia present in a Wilm's tumor. This is not for our patient, but just so that we can help our pediatricians that this is one for anaplasia specimen which shows anaplasia. I am just going to skip it in favor of missing time. Dr. Sujata, my question to you is, we talked about two different modalities of treatment. And do you think that those two treatment modalities, the American versus the European, are they different in their treatment approaches?
Yeah, they're different in their treatment approaches because the American system of the Children's Oncology Group prefers an upfront nephrectomy in most cases. And the assessment of histopathology is clean and clear without any chemotherapy effects on it. And it is clearly based on the presence of anaplasia or the absence of anaplasia. Absence of anaplasia makes it favorable histology, whereas presence makes it unfavorable and upgrades the necessary chemo versus radiation part of it, in brief. Whereas in PSYOP classification, you have low risk, intermediate risk, high risk based on the response to the treatment. And that guides us in further treatment.
We move on to our second case. So this was a young 1-year, 7-month-old child, firstborn of a non-consanguineous marriage, and she presented as a well child where the mother felt a lump in the abdomen while bathing. Remember, this is the commonest presentation for a Wilm's tumor, that an absolutely well child the mother just feels it while playing with the child or while bathing the child. There was no other history of fever or hematuria or bleeding from any sides, though she did have a history of having other features present. So she had corneal opacities present, had been picked up as a Peters anomaly type 2 before, but no genitourinary abnormalities, hemihypertrophy or organomegaly present, no developmental delay, a mild developmental delay present, but not significant there. A CT scan had been done outside, and here we had found, so again, the importance of doing a proper imaging, we found that there were bilateral renal masses. Though the mom felt only one mass, there were bilateral renal masses. The left kidney was 9 into 12 centimeters approximately, whereas the right kidney, the lesions were smaller, that was about 4 by 5 centimeters, well circumscribed lesions were present. Renal vein and IVC were not involved, liver was not involved, and we could not radiologically find any involvement of the lymph nodes either. Dr. Sujata, what are the conditions, what congenital conditions would you be looking at when you're looking at a Wilm's tumor?
So some of the syndromes that we look at is like a Wagner syndrome, which is Wilm's tumor, aniridia, mental retardation, and genitourinary abnormalities. So a complete physical exam of the entire baby is very important to not miss any of these syndromes, because syndromic Wilm's is an important thing to know. Second thing would be like a Danish-Dash syndrome, wherein you have a congenital nephropathy. And in a male, usually there is abnormalities with genitalia in addition to Wilm's tumor. But in a female, you can have normal genitalia and still have Wilm's tumor. A third would be a hemihypertrophy or the Beckett-Weidman syndrome, which is generally an overgrowth syndrome along with hepatoblastoma, cancer predisposition, and most commonly seen as Wilm's tumor or hepatoblastoma.
Yeah. Dr. Hiren, can you go through the images with us, because this was a bilateral renal tumor now, not a unilateral tumor. So would the imaging, would you be looking at things differently in this patient?
Yeah, so on these images, we can see that the left-sided renal tumor was markedly expansile, and it was, if you see in the prevertebral region, it is crossing midline also. So when that the lesion crosses midline, that is one of the risk factor, and that is considered as high risk for surgery. And simultaneously, we can see that in the right kidney also, we are seeing a similar heterogeneously enhancing mass lesion. So the density and enhancement is heterogeneous. That makes one of the feature that it looks like more of a Wilm tumor rather than the nephrogenic rest. And the size of the lesion is definitely more than 2 centimeter. That is also like, as grossly we do come across that when the size of the lesion is more than 1.8 centimeter, then it's more likely to be a Wilm tumor in such a bilateral Wilm tumor case scenario. And here is the same thing. We are trying to show that the lesion on the left side renal mass, it is crossing the midline. And if you see on the last image, Sujata reconstructed, you can see that the lesion looks like ball shape, like it is coming from the outer cortex. Anyway, it's coming from the anterior cortex, if you see, and the posterior cortex is spared. That is the information that we can give to the surgeons. Next image. Here are the vascular assessment. You can see that the lesion is splaying and attenuating the left renal artery. I think this patient might have at the time some hypertension also, if I remember. This was the same patient or not, I am not sure. But so that sometimes the lesion itself can cause attenuation or narrowing, external mass effect narrowing of the renal vessels. So CT is very good in showing those kind of information relationship of the vessel with the mass. And last image, we can see that the veins were patent. Next image. Here we can see that yellow arrow on top, there is some sort of linear band kind of thing. So that band kind of hyperdensity, it was less than 2 centimeter, and it was not changing on interval scan. So that we thought that this looked like more of a nephrogenic rest, because it was not looking like more than 2 centimeter. It was not round or spherical in shape. It was not distorting the parenchyma. It was looking homogeneous, some sort of. So that was looking like a nephrogenic rest. But yeah, the larger lesion was definitely a Wilm tumor, and it was seen on both sides.
So how would you differentiate a nephrogenic rest from a bilateral renal mass?
Yeah, so a few of the points I already mentioned, but nobody can 100% predict that this is going to be a nephrogenic rest only. But there are certain criteria. If the lesion is very homogeneous and it is poorly enhancing or non-enhancing on the post-contrast, either CT or MRI, and the size of the lesion is less than 2 centimeter, and that usually doesn't distort the parenchyma. It will be within the parenchyma, but it will not cause bulging or adjacent mass effect. So that are most likely to be nephrogenic rest. On the contrary, if you see heterogeneity within the lesion, size of the lesion is more than 2 centimeter, and if it is expanding or distorting the adjacent parenchyma, it is more likely to be a imaging wise.
We did this patient. So actually a stage 5 doesn't need to get a biopsy done, but we did do it because she had these congenital malformations that we were not very sure what we were dealing with.
Okay, so once again, this is a triphasic Wilm tumor, which is composed of round blue cell tumor, which is in sheets, which is the mesenchymal component and the epithelial component consisting of abortive tubules. Ma'am, you can go ahead.
So we called her a stage 5 Wilm tumors. We discussed that she didn't have any other developmental or congenital syndromes that were associated with it. And as Dr. Sujata mentioned earlier in the staging, we stage each tumor, each kidney individually. So both were stage 1 individually. It is very important to note that a stage 5 is not bigger than a stage 4. It's just that you have to individually stage each one. And even a bilateral Wilms is very, very treatable for this patient. So we offered them chemotherapy first, and then we looked at the surgery. So this is both a pre and a post scan that you can see, and there is a reduction in the mass of the tumor that you can see with this patient post the chemotherapy. Dr. Hiren, would you like to comment? So you can see the big mass.
Yeah, so here it is quite visible. I need not to be explained that you can see that the left renal mass, it has more than 50% shrunk in size. It was crossing midline before. Now we are not seeing anything extension beyond the midline. Even the right side renal tumor also has decreased in size.
Dr. Rasiksha, the question for you is, so she first had a left-sided nephrectomy and later had a partial nephrectomy the next time. So the question to you is, could we look at bilateral partial nephrectomies in our renal bilateral Wilms tumors, or is there? Are you looking at a minimum amount of renal tissue to be available before to salvage the patient, or would you consider bilateral?
So, I mean, wherever possible, we should do partial nephrectomy. I mean, if possible, on both sides. But often the one side tumor is too large and it may not be amenable to do the partial nephrectomy in these patients. And then we may end up doing complete nephrectomy on one side and partial on other sides. However, on both sides, if we have a small tumor, we will consider doing partial nephrectomy on both sides.
Yeah. And what is the minimum amount of renal tissue, sir, that you need to conserve?
If we can save 50% of the kidney on one side, I think it is sufficient for the lifelong, most of the time.
Shivali, would you go through the histopathological findings for us? So this was the left nephrectomy as a gross specimen.
Okay, yes, ma'am. Ma'am, histopath, please. Left-sided hysterectomy specimen, which we grossed, and on that we could basically see that much of less than 1/3 of the viable tumor was there, and it was a predominantly biphasic Wilms tumor, epithelial component and a few mesenchymal, and blastomal component was less than 1%. There was no anaplasia, no renal vein involvement, all lymph nodes were negative. And as per the SIOP classification, we called it as regressive type nephroblastoma.
And then we did a partial nephrectomy on the right side. So this is the gross for the partial nephrectomy, and this is the histopath for the partial nephrectomy. Any changes that you could see between the two left and the right side, Shivali?
Ma'am, mostly this also tumor was the viable tumor was less than 1/3, and basically the viable tumor was composed more less than the more less than the left side. It was like less than 5%, and whatever these changes, like down changes, are all these post chemotherapy changes like fibrosis, rhabdomyomatous change, hyalinization, and a big cystic change can be seen. Macrophages. So the tumor was very much less than the other part, and for this also we called it that regressive type nephroblastoma.
So this really helped to put it as a favorable diagnosis for us, that she was responding very well to therapy. Again, as Dr. Kurkure mentioned in her initial presentation, shared care is a very important component of oncology care as well. This family hailed from Assam. So once we had done the nephrectomy, we then continued the treatment at Dibrugarh, Assam for them. Shruti, I will take another 10 minutes more. We have 2 more interesting cases, and then we'll try and wrap it up quickly for you. So Dr. Hiren, because radiology becomes so important for diagnosing a Wilms tumor, is there a differential diagnosis based on the radiology itself?
Yeah, so there are a large list of conditions which can present as a renal mass in pediatric age group, and it differs even like in neonatal age group we might see the mesoblastic nephroma, those kind of thing, which is common in the neonatal age group. And as the baby or the child progresses, then we will see after second decade or something in the after 10 years, we'll see RCC, those kind of lesions. And if we see associated lymphadenopathy and homogeneously enhancing lesion, then we have to think of lymphoma also as a possibility. And sometimes if you see many skeletal metastases, then clear cell sarcoma also one of the differentials that we have to take into account. So considering time, I'm not going to detail, but there are some peculiar conditions with each cancer. But Wilms tumor is the most common tumor that we find in this kind of infancy and those kind of age group. But if you have some other clues, as we have mentioned on this table, then you should have a red mark and you can raise other possibility of testing.
So I'll move on to our next case that we see. These are all different presentations for renal masses, but not Wilms tumors itself. And they turned out to be different cases that we could see. This was a lymphoma that we saw in a post-transplant patient, and so on. Ma'am, I will come to you with the next question. So this is the third case that we saw. This was a 1 year, 4 months old female child, non-consanguineous marriage, presented with hematuria for 10 days. Again, a common presentation for Wilms tumors. No dysmorphism, no hypertension, a firm mass felt on the right side of the abdomen. But when we did the imaging, what we found was that this looks to us to be a stage 4 disease with metastasis both to the lungs and also to the right side of the right-sided femur as well. Now, Wilm's tumor generally does not metastasize to bones. It's very rare that it will metastasize to the bones. So we asked for an image-guided biopsy of the renal mass. Imaging, was there anything that made you feel that this could be any different, Hiren?
Of course, like when we see the large mass, first possibility of Wilms only comes, but this lesion had some this kind of subcapsular hypoattenuating area, so that could be fluid collection or hemorrhage within the lesion. And we saw, can you go to the next slide? We saw in this patient, just this showing claw sign in that. This patient had lung metastasis also, and next slide. So if you see that this kind of patient had mediastinal adenopathy also, and one of the bone lesion was there. So in Wilms tumor, this kind of mediastinal adenopathy and bone lesions are not that much common. So that was some sort of atypical finding for Wilms. So when we see this kind of finding, then we could think that this could be something else also, and we should get the tissue biopsy and tissue diagnosis.
So lung involvement is generally parenchymal in a Wilms tumor. It's not nodal. And when we did the histopathology, Dr. Khandelkar, could you tell us about the histopath? Was it different, or was it a Wilms itself?
No, definitely you can look at it and say it's not a Wilms. You could see groups of small cells if you can move the arrow, and large areas of necrosis where your arrow is. And the higher power of this, if you can go to the next slide. Next, please. You can see that these are larger cells as compared to Wilms, with lots of cytoplasm. And you can see nucleoli which are prominent within the nucleus. And this points to a rhabdoid tumor and not Wilms.
Yeah. So if there are any PG students, then this is classical for a rhabdoid tumor, where you have these big cells with the prominent nucleoli present. So this was a rhabdoid tumor. For us, the red flags were the bone involvement and the mediastinal lymph node, although the age in the presentation was for a renal mass itself. Our fourth case, again, very unusual. This was a child who was 8 years, 4 months old. So a higher age group from the normal common presentation that we see for Wilms tumors. He had been referred to us because they found bilateral renal masses that were present in this child. There was a history of febrile illness, and he had been diagnosed to have UTI quite frequently previously also. When we examined him, we couldn't feel a lump. The genitals were normal, but ultrasound run outside showed that there were bilateral renal masses, and they were both the kidneys were small for his age. So again, a red flag for us that the kidneys looked smaller for age for us. Again, and the age was outside our age range. We actually got a PET scan was also done outside, which showed that there was a small low-grade FTP uptake in this patient as well, and a urine examination was clear at that time. So Hiren, the radiology for your discussion. I think Dr. Hiren.
Yeah. I'm here only. So can you go to the next slide?
Yeah. So you could see these lesions in the kidney.
Ma'am, I think the slide is not getting forwarded. Like we are still on the case history only.
Oh, I could see.
We can see the slide.
Oh, you can see the slide. Okay, it's not moving. I don't know what happened.
So he's sticking the beads. Like what Anumamiji does, no? She'll do that, putting the beads. Like that it is.
Okay. Now I can see the.
What are you doing, Dadu?
I'm so I request the others to mute, please.
Not able to see. Papa? Wait, I'll show you again.
I would request all the participants to mute, please.
Okay, can you just go back to the
black background? Mein kya hai?
A tree, Papa. This par Manan is putting colored dots.
So what was happening in this patient that both the kidneys were small in size, and we were seeing that the normal looking parenchyma which was hypertrophied, and it was looking like nodular at certain areas. But the vascular, but on USC color Doppler and the vessels were looking normally traversing through those areas. So whenever there is some mass or nodules, they will displace the vessels. But in this kind of condition, the vessels were normally coursing through this area. So it was looking like some sort of hypertrophy of the normal looking parenchyma, and it was behaving like a pseudotumor. So this is not actually a pathology. And these are the different weighted images. Different weighted images was looking normal. It was not showing resected difference, which we expect in the malignant tumor. So there was a certain clue on MRI and USC that this could be just a hypertrophied normal looking parenchyma, which is mimicking like a pseudotumors.
And the PET scan just had this little focal uptake. Dr. Sujata, why do you think that the PET scan had an uptake? Normally, Wilms is not a tumor that is FDG avid.
So even inflammation, anything which has inflammation or metabolically active, so that can be tumor or inflammation, can show PET avidity.
So a PET may not actually be diagnostic for us.
Cancers as well as osteomyelitis and things like that also.
So what we ended up doing with this patient is that we asked for a laparoscopy to be done for this and to see the structure of the kidney itself, and then to try and do it. And took biopsies from that. And Dr. Khandalkar, what was the biopsy for you?
The biopsy is taken from both kidneys, one right upper pole and left lower pole, showed the same picture. There was no tumor at all. It was like an end-stage kidney with fibrosed atrophic glomeruli, inflammation, and vascular thickening and tubular necrosis.
So there is no evidence of tumor in this. This is just a case of chronic renal disease. And once we investigated it further, we found that this was PU valves and therefore pyelonephritis and chronic end-stage renal disease. So we will stop here. We just take home messages for everyone here that Wilms is the commonest tumor that we see at the abdominal masses present, but survivals are really good. Even our stage 3 and stage 4 have very good survivals, and overall survivals range above 90% in most cases. So very, very treatable. For those of you who are scared about cancer, this is one tumor that you should not be scared about, and you should refer for further care to patients. We believe in shared care, so we will start treatment and we'll send back the patient to you for follow-ups and further treatment, and they will live their normal life throughout. Proper radiology and staging upfront is very, very important, because this tells us how to guide the treatment for us. Most of the cases, if we can avoid an upfront nephrectomy if they're big tumors, then it actually helps to avoid radiation in these patients as well. So there are two approaches that we've discussed, the SIOP or the European approach and the American approach, which are different. And in India, what we're actually doing is what we call the umbrella approach, where we look at the radiology, sit with everyone at the tumor board and decide what is the best way forward. For those of pediatric surgeons in the group, please remember to do lymph node sampling in these patients, because it helps to better stage the disease for us. Sometimes we may have to use IHC in our markers, but generally for a plain Wilms or a classical Wilms, it's not important. But histopathology is very, very important. So having the specimen sent to a good histopathologist will be of extreme importance to all of us. There is a role for partial nephrectomy in Wilms tumors, and we are trying to move towards more and more organ sparing surgeries to be done. But what we would like to end with is that be aware of the red flags that are there. All renal masses are not Wilms tumors, and you will often have something that will confuse you or kind of make you say that this doesn't look like a classical Wilms. Most importantly, team approach is actually essential for improving survivals. And what we can share with you is, of the 33 Wilms that we've seen, 20 have taken complete treatment with us, or complete or shared care treatment with us. 8 have come only for surgery, 5 came just for second opinions. But of the 20 that we have seen, only 1 child has died because of a recurrence. All the others have actually finished treatment or are on the verge of completing treatment. Only 1 child progressed while on chemotherapy and had to be upstage, and 1 child was upstage, as Dr. Sujata mentioned, because of a lack of lymph node sampling. We haven't documented any peritoneal spills in any of our cases because treatment has actually been planned properly and executed properly, because we discussed them in our tumor boards. We have not seen any relapses till date. So what we can say is that our survival rates are at least 95%, only 1 death of the 20 that we have actually looked after so far. It would be amiss on my part to say that we are the core group. We cannot function without having a very good support system which exists at SRCC. The pediatric surgery team helps us, guides us throughout, and they're a core part of it. But the pediatric anesthesia team, who assists them in all their surgeries, an excellent state-of-the-art lab that is available with us, blood bank to help support the care of our patients, because a lot of times we need to give them supportive care in terms of blood transfusions or management of febrile neutropenia. A very good intensive care team that is always there to support us for our patients, both pre-op and post-op as well. And a good team of nurses with whom we function, and we rely on them for taking care of our patients. Last but not the least, the families of the patients who kind of place their trust in us to ensure that we are going to give them the best care that is possible for their child.
And Ruchira CSR team.
Yes, and an excellent CSR team. Yes, I should have put it there. A lot of our patients are funded patients because they cannot afford the treatment on their own. So our CSR team looks for funds for them and make sure that they get their treatment. So treatment is not denied for any patient at SRCC. Thank you so much. Thank you, Shruti, for giving us that little extra overtime as well. And I'm sorry we crossed our limits.
Thank you so much to each of the team member for the excellent panel. We at SRCC, we do strive for the best, and you guys just proved it. So next, I would like to welcome our next team, that is the Spina Bifida Clinic. The topic will be team approach in the comprehensive management of Spina Bifida patient. I would like to welcome Dr. Amrish Vaidya, who is our senior pediatric general and laparoscopic surgeon, who is one of the prominent member of the Spina Bifida Clinic. So over to you, please.
Thank you. Okay, so our Spina Bifida Clinic is one more multi-specialty clinic at our hospital, and this is very important for the holistic management of the child with Spina Bifida. Now, we know that Spina Bifida is a condition with incomplete, where the child is born with an incomplete covering of the spinal cord, and the spinal cord is exposed to the exterior or in a fluid-filled sac. And how common is Spina Bifida? Well, worldwide, the incidence is about 1 to 2 per 1,000 live births, but in India, it is 4 to 5 per 1,000 live births, and more cases are seen in the northern belts. Why is Spina Bifida caused? It's caused because of genetic and environmental factors. With its poor nutrition amongst mothers and a lack of vitamin B12 are important factors. By and large, it is a disease of the lower socioeconomic class, and antenatal screening is, of course, recommended by ultrasound, and in certain cases, a medical termination of pregnancy is something that might be advised. Because it is a disease of the lower socioeconomic class, it is even more important that clinics like ours exist and provide these services. So just a brief recount of how Spina Bifida affects the child. So in a Spina Bifida, the nerves below the swelling may be compromised, and the nerves below the swelling are the ones that innervate the lower limbs, they innervate the muscles which are responsible for continence. And so the consequences can be a loss of power in the lower limbs. It can be poor control of urine and stools. Spina Bifida is also associated with orthopedic deformities and with hydrocephalus. And holistic care, I must stress, is necessary throughout life. Because we know that children with complex conditions and their families have the same aspirations for successful adult living as typical children, and they have less resilience than other children to deal with the challenges of life. They've already started out at a slight disadvantage. And another fact about Spina Bifida is that by the age of 12, a child will have gone through at least 4 to 5 surgical procedures. At birth, there is the repair of the meningomyelocele. Very often, they require an insertion of a ventriculoperitoneal shunt. In early childhood, maybe a number of orthopedic procedures may be required. Other possible procedures may be revisions of VP shunts, detethering of the cord. They might require procedures for urine and stool incontinence. They may have bed sores. They may lead flaps. They may have osteomyelitis. There are lots of things that these children have to go through. Now, earlier, a lot of children who were born with Spina Bifida didn't survive. And so the natural history of many impairments that babies were born with were unclear, because only recently now these children have lived well into adulthood. And now we are seeing, by documenting their physical health and functional outcomes, that certain early interventions or interventions which are made in good time may be hugely responsible for giving them a better quality of life later. And so we recommend that we follow a lifelong model for the care of Spina Bifida. And there are 4 major time points at which interventions are required. One is in early childhood, then is at the school age period. At adolescence, the challenges faced by these young adults is completely different. And as young adults, once they get into earning life, again, they face different challenges. And these challenges are in 3 main domains. It's in the domain of health and self-management. it's in the domain of personal and social relationships, and it's in the domain of education, employment, and income support. And all these three really have to be looked at if holistic care is to be provided. So we are trying to offer this in the form of a spina bifida clinic. And in the clinic, we have at hand a general pediatrician, a neurosurgeon, a urologist, an orthopedic surgeon, a rehabilitation specialist, along with counselors, obesity consultants, if necessary, plastic surgeons, dermatologists, and dentists. Now, the important thing is that this clinic is held at a fixed time once a week by appointment. And when a child who sometimes comes from far away from our hospital is in any case physically disadvantaged and has to go through a lot of effort to make it from one place to another, he should not be in a situation where he sees a neurosurgeon on one day and then is asked to come and see a urologist the next day. At one visit to the hospital, all his doctors should be available at one spot so that there is minimum movement for this child and maximum advantage out of one single visit that they make to a hospital. So who is the core team at our Spina Bifida clinic? So we have two very eminent neurosurgeons, Dr. Naresh Biani and Dr. Sumit Pawar. Our orthopedic surgeons, Dr. Taral Nagda and Dr. Avi Shah, take a keen interest in this. I am one of the urologists along with Dr. Amit Nagpuri, who looks after the continence aspect in these children. We have a general pediatrician, Dr. Nehal Shah, and a rehabilitation specialist, Dr. Nisha Agarwal. Now, this is our core team, but we have other specialists who are available as and when required. So how does the clinic work? See, the initial referral may be to any specialist. Sometimes children may come to me directly with a problem of incontinence. Sometimes they may go to our neurosurgeons with the actual spina bifida or with some other issues. They may go to an orthopedic surgeon with certain deformities. And once they come to any specialist, we enroll them in the spina bifida clinic. The reason for enrolling them is that we give them very, very special consulting rates to see every specialist. They don't need to spend money paying for individual consultations of all our specialists. What is generally done is that a general evaluation is done by a pediatrician, in our case, Dr. Nehal Shah, and an initial assessment is done by a neurosurgeon, an orthopedic surgeon, a urologist, and a rehabilitation specialist. We consider these four specialties the core specialties of a spina bifida care. And once a child has been seen by these 5 doctors, then a treatment plan is formulated. Further visits are done as necessary in the treatment plan, but every time a child comes to the hospital, he doesn't necessarily see all the specialists. Each specialist can be seen only as much as necessary. In any emergency situation, the parents are advised to contact our general pediatrician, and then this general pediatrician will determine if any of the specialists really need to see the child. And besides a yearly review that's done by the full team, intermittent appointments or intermittent visits are planned after consulting the general pediatrician. For instance, halfway through the year, if the child develops a urinary tract infection and something has to be seen regarding his urinary symptoms, then an appointment will be made by me to see the child. However, if there are any issues which need to be assessed by a neurosurgeon or by an orthopedic surgeon, then our general pediatrician will recommend that those doctors be seen. This helps us to optimize the visits by the child. It also helps to save money because the fewer specialists that see the child, the lesser is the amount that they pay for a visit. And we try and optimize their time and their
Dr. Vaidya, we can't hear you.
Okay. Just a minute. Let me just see.
No, it's clear now.
Yeah,
it's clear now.
Amrish, please proceed. Yeah, please proceed.
Yeah, sorry. Can you hear me now? Hello, am I audible?
Yes, yes,
Okay.
yes.
So when we formulate a treatment plan, of course, we check on the kind of spina bifida, the level and size and state of the sac, the degree of neurological involvement, the presence or absence of hydrocephalus. We check for continence, we check for orthopedic deformities, and we check the family dynamics, and all this will help us to formulate a plan. Because what do we believe in our spina bifida clinic? See, spina bifida is not a condition that you can cure. You can only manage this disease. And whenever it is possible to manage but not cure a disease, it's important to determine how far the treatment and disease compromise a child's quality of life. And once we have determined this, informed judgments between all of us can be made as to whether or not which treatment modality is going to be appropriate. And where there is a choice, which choice would be the best option for the child. So having said this, I will hand over to Dr. Sumit Pawar to tell us about how neurosurgeons are part of this clinic and what they do for a child with spina bifida. Over to you, Sumit.
Thank you so much, sir. Is my screen visible?
Not yet, sir.
Yes.
Coming up. Yeah.
Yes, it's visible now, Sumit.
Fantastic, sir. I think there's some time lag between the
Sumit, we've lost you. You're not audible.
Hi, sir. Am I audible right now?
Yes, Sumit. Yeah.
Sir, am I
Please
audible?
proceed.
Yeah,
yes.
sorry. So, like I was saying, thank you, Dr. Amish Vaidya, for introducing the topic for all of us. Spina bifida comes in many forms and shapes and sizes. It can be a simple innocuous, just a sinus pit. It can be a massive swelling on the back. It can have varied presentations, like Dr. Amish Vaidya also has highlighted. Basic for us to remember is that this is how a normal spine looks like. It can have a spina bifida occulta, where the skin is intact. The bones are slightly opened up, they are not fused from behind, but the meninges and the spinal cord or the nerve roots are perfectly in position. You can have just a meningocele also, in which the skin is intact and the dura has herniated outside, but the neural elements are well within the bony spinal canal. When the neural elements come out of the bony spinal canal, that is when we call it meningomyelocele. There is a very complicated and extensive classification of spina bifida. It can be open and closed. Basic thing to remember is that when the skin is intact, it is a meningocele. It's a closed spinal dysraphism or closed spina bifida. If the skin is open, it becomes an open meningomyelocele. So, like you can see in just one example of a case over here, who you can see dysplastic. It's an abnormal skin. It was open in utero, and a slight body has tried to give her a dysplastic covering over it. This is the MRI of the child. Child has a Chiari herniation. He has some hydrocephalus. He has an extensive massive swelling over the lower lumbosacral region. The spinal cord is herniating out of the canal into the sac. There are some dysplastic nerve roots attached to the skin also. This patient was taken up for surgery. There are surgical videos. The entire sac has been opened. The neural placard has been reconstructed. The dura, flimsy layer of dura can be seen. It was again reconstructed. And with the musculofacial flap, it was closed primarily. Similar cases, we can keep on seeing. There is a big difference in the clinical presentation of the skin and what we see inside. This is an extremely complicated case of a spinal dysraphism, which has features of diastomatomyelia, and the cord is split into two parts. Plus, he has a Chiari herniation, which is coming up to C6 level. The tonsils are coming down, has a hydrocephalus. And with this, everything was repaired. This requires a complete team approach because, like Dr. Amish said, all the nerve roots below this point, as well as because of the stretch, the nerve roots above this point are going to be affected because of the stretch and because of the dysplastic nerve roots, because of the exposure of the neural tissue to the amniotic fluid when the child was in the womb. This is one child in which we had done a repair for a very, very complicated MMC. You'll see the video after some time. A very innocuous, very, very innocuous looking presentation, that just a swelling on the back can be very, very difficult to treat with the lipomyelomeningocele, where the spinal cord is stuck to the fatty adipose tissue and has herniated outside the spinal canal. It can be a very difficult looking dangerous swelling, whereas actually it is just a terminal myelocystocele with a tethered cord, very, very simple and easy to treat. The outcomes vary significantly based on the initial presentation. We operate these cases fully endoscopically as well. Our job over here is to do a neurosurgical release of the stretched and pulled and stuck neural elements, which are stuck to the adipose tissue or to the skin. Here we can see that we have done a fully endoscopic surgery over here. This is one of the first endoscopic surgery done in India for a spina bifida. It was endoscopic detethering of cord. We use neuromonitoring for every single case so that we are very sure of what we are cutting. The fatty phylum is identified. We check that no sphincter and no lower limb muscles are stimulated once we are stimulating, passing an electric current through this phylum. Once we are sure of it, we coagulate and we cut it. This is another case of an open detethering. Patient had tethered cord as well as diastematomyelia, so that's why a very big incision was taken. But this shows us very nicely what we exactly do in the surgery. The dura is open, the arachnoid is open. You can see all these are the cord equina, all the nerve roots over here, and this is a very slightly different colored phylum that can be seen. The vein helps us identify the phylum. We separate it from the of the cord equina, regulate the vein, and then it is incised. This is a very, very small incision. It's a Jewell's forceps, about hardly 1 millimeter in thickness. As soon as we cut, significantly moved upwards about by 1 centimeter. You can see the distance between these two elements over here. There is still additional arachnoid tissue which needs to be separated. And once that was separated, there is a good distance between the two, which signifies that there was significant tethering. Now, there can be a case with a sinus pit. We don't know if it is connected inside or not. People come to us with this kind of query, what is to be done? We have to do imaging over here. We can see that the cord is ending right at there's no low-lying conus. The cord is ending at L1 and 2. There is no connection of the sinus pit to the dural sac. There is no tethering of cord. And in this case, all we can do is just observe and advise that if there is any abnormality in the crawling, if the patient is keeping the legs inturned, if patient is having frequent falls or urinary symptoms, only in that case you should come and we should think of a surgical intervention in that case. This kind of a very innocuous looking pit can have a very, very difficult presentation and it's very different inside. Patient has a syrinx, low-lying tethered cord, low-lying conus, and the sinus pit is connected to the dural sac. There is a very, very high chance of an infection and a meningitis if we don't operate this child as soon as possible. Diastematomyelia is another very difficult type of spina bifida that needs correction. We have already seen this case before, and the surgical management is very, very good. They are nicely operated. We have to keep an eye for the orthopedic and the deformity that they might develop, and we have to keep an eye for the urinary symptoms that might come up after the surgery also. Diastematomyelia has typically a very high rate of retethering, in which case they might require a surgery at a later date. Typically, open MMC will need surgery as soon as the patient is born, within 2 to 3 days after a good antibiotic cover, once they have slightly stabilized. Closed MMC, on the other hand, needs surgery between 6 months to 9 months of age, once they have gained some weight and everything, before the child is sitting and walking, to give his neurology back to him. Typically, the outcome depends on the pre-operative neurological status of the patient. If patient has no movement in the leg, it is very unlikely that he will gain movement after the surgery because the nerve have been damaged in the intrauterine time itself. So to conclude, malformations are pretty common. They are very, very preventable, like Dr. Vaidya has said, with the vitamin B12 supplementation. Once identified, they are amenable to treatment and have a good outcome if done at the right age. Minimal invasive techniques have a major role to play because of lesser stay, early mobilization, and less blood loss. Here, I would like to highlight our fetal medicine department and Spina Bifida clinic. We have a fetal medicine department in which the same team of Spina Bifida clinic sits over there. Suppose a female is diagnosed with antenatally that she has a Spina Bifida, whether she should abort or not, this decision, we help in taking a decision based on the multiple parameters. A neurologist, neurosurgeon, orthopedic surgeon, pediatric surgeon, and a urologist, everyone is sitting together and we're discussing whether or not the child has a good outcome, or are we expecting that the child is going to have a very poor neurological outcome. And based on that, we can advise them appropriately whether they can continue the pregnancy, whether they need a C-section or a normal delivery, whether we have to do surgery immediately after birth or at later stage, and that guidance helps the patient a lot. The Spina Bifida clinic, Dr. Vaidya has already highlighted the importance over here. We can have a look over here. This child, pre-operative, had a foot deformity with tethering of cord. In the same sitting, surgery was done by orthopedic surgeon and neurosurgeon. And we can see that the child post-op 6 weeks, he is walking normally. He was a football player's son. So the female from Manipur was very, very keen that even her son has a good outcome. Maybe even he wants to become a football player. And it's our job to ensure that he is not staying behind just because of a deformity or any weakness that he cannot play because of the deformity. This is a video shared by the parents of that very complicated case that we have done of a diastematomyelia with meningomyelocele, with tethering of cord. And this is the video that dad sent on the birthday. That child is right now 1 year of age. This is his progression over since 4 months of age till 1 year. He's crawling, he's sitting, he's becoming a girl in this for a video. And essentially leading an absolutely normal life with normal urology, normal bones, and normal neurology. This is our endpoint that we should achieve with a team effort only. Thank you so much.
Thank you very much, Sumit. I think you've really highlighted how you have interacted with all the other specialists to give the best possible outcome to the patients. I'd like to ask Dr. Taral Nagda to step in and tell us how orthopedic surgeons are part of the team and how they help us to manage these children with Spina Bifida. Taral, are you on? Yeah, will you unmute yourself, Taral?
Yeah, can you hear me now? Okay.
That's fine. Yeah.
Okay. Awesome. My screen is seen here.
Yes, we can see it.
Okay. Okay. So I'm just going to share a story to tell you all how the orthopedic surgeon works. What is the role of a pediatric orthopedic surgeon in management of Spina Bifida? So this is Abbas's story, and this was his photograph when he was born. This was around 4 years back, and this is the condition of his low limbs. So the role of orthopedic surgeon in Spina Bifida comes into picture because, as Amrish said, it affects the nerves which supply the lower limbs. And because of the affection of the nerves, there is paralysis, there is sensory loss, there are deformities, and all this creates difficulty in ambulation. And the job of an orthopedic surgeon is to restore ambulation to a child with Spina Bifida to the best possible manner. So I'm just going to ask a question to the people who are attending this session. And the question is, you see this child, this is at birth. What is your assumption? Please type in the chat box as to what you feel could be the fate of this child. Will this child ever be able to walk? Will he be able to go to school? Will he be able to, will he be wheelchair bound? Will he be a productive member of the society? What will he be? This child was fortunate because on day one, his meningomyelocele was repaired by a very competent pediatric surgeon. And then the child was referred to us for management of the orthopedic problem. So as people are typing in the chat box, I'm going to take the story ahead. So this is how his feet looked. So feet are deformed. So this is a secondary clubfoot-like condition which needs to be treated. The knees are in extension and child has hips which are completely dislocated and hips are in almost 45-degree flexion. So this is deformity which the child has. The job of the pediatric orthopedic surgeon is to set in the priority and plan the treatment. And as we plan the treatment, the feet come first. And what we started doing is serial plasters for the feet without anesthesia. This is done on weekly basis. And this is done by a method which is known as Ponseti's method. Very rigid looking feet, but as you keep plastering, feet go on correcting. And you can see as the plasters are being put, we are able to get little flexion in the knee joint, more correction of the feet. And at end of these plasters, we were able to get the feet and knee completely straight. The issue was the hips now. If this child had to stand, these hips have to be in and they have to be in line with the spine. This child had almost 60-degree flexion deformity of the hip. And that occurs essentially because this was an L2-3 level spina bifida, which means that his hip flexors were working, hip adductors were working, but hip extensors and abductors were not working. He had no abduction in the hip, no extension in the hip. And that's why there was a deformity which he had in the hip joint. However, his knee flexors were working. So one of the decision-making tools, what we use is a quadricep power. A child who has good quadricep power, it's worthwhile doing something to reconstruct proximally because these children have capacity to ambulate with or without support. So this child had good quadricep power. His both hips were dislocated. And the sort of a teaching in pediatric orthopedic textbooks is that a child with spina bifida with bilateral hip dislocation should be left alone. We should not do anything because putting the hips back does not improve the functional status. And that was a dilemma. And that is what has been written up in the recent literature. But the issue was this child had bilateral flexion deformity of the hip. And it was very difficult for him to even stand. And Amrish spoke about aspiration of the parents. The mother has worked very hard on the child. She wanted that this child goes to school, becomes an active member of the society. And that led us to search the literature. And I found a very old article from 1959 from Sharad, which spoke about a tendon transfer. A tendon transfer where psoas, which is a hip flexor, is transferred to the greater trochanter to now act as a hip abductor and extensor. So we went ahead with the surgery. We did open reduction of the hip, as has been shown here. And then we did femoral osteotomy, reshaped the proximal femur so that the head of the femur could sit into the acetabular. And then, as Sharad suggested, we transferred the psoas muscle to the greater trochanter to act as an abductor and extensor. And this was the post-operative picture after a bilateral surgery. And to our surprise, after 4 months, these hips stayed in. After 1 year also they stayed in, and not did thus the x-rays improved, but he was able to stand in a correct alignment. Not only he was able to stand, he started taking his first steps with help of an excellent rehab program, which this child underwent. And then he was able to walk, dance, be part of his peer groups, take part in birthday celebrations, be part of the school socials, and took part in all the activities which his school was supposed to organize along with his peer group. So here you can see that the red signal which the life had created for him now goes into yellow, and soon there is going to be a green signal where he is going to zoom into a very active life. So transformation like this from a child in whom there is deformity, there is despair, there is no future, it can be converted into a state of ambulation where child can be active part of society through help of an orthopedic intervention. So that was just an introduction to what an orthopedic surgeon can do for spina bifida. I'm going to hand over now to Dr. Avisha and ask him to highlight overall role of an orthopedic surgeon in management of spina bifida. Avi, first question I'm going to ask you about this is, when should the child be referred to a pediatric orthopedic surgeon? How early?
The earlier, the better. So you do not have to wait for things to be sorted one at a time. See, the orthopedic problems of the spina bifida child can be treated simultaneously or right as soon as the spina bifida part has been closed or cleared. So we should not wait till the child is much older, because similarly, like in the case you have shown, the earlier the child comes, we can get away with the Ponseti method and smaller procedures, maybe smaller surgeries, and get it done quickly. The older child, once the deformities become more severe, they end up requiring more major reconstructive procedures, which may be avoided if they come to us in a younger age group.
Next question I'm going to ask you is, what are the common procedures which are done on the foot, for a child with spina bifida?
Taral, you were muted. You'll have to unmute when you ask the question.
Yeah. So, Avi, one more question I wanted to ask you.
Who've had spina bifida as well. So, clubfoot is a major part with children with spina bifida. The other issues we have seen is congenital vertical talus, where the talus and navicular joint is dislocated, and these children, when they walk, develop a lot of pressure and sores. The other issue is the equino-cavovirus type of foot, where the foot is completely turned inwards like this. And these children, and most of the time, they will require some form of plastering and surgery to get their foot corrected. And even after correction, they do require some form of splints or shoes, because these children are quite prone to get sores and injuries because of their sensory issues.
Any other questions from the audience about orthopedic intervention? Ravi, what is the role of tendon transfer? There are children who walk on the heel and sometimes develop sore on the heels because of calcaneus deformity.
Yes.
So is there any role for tendon transfers?
For tendon transfer, we have to be really careful, because we need to really make sure what is the level of the MMC, what power is there in which muscle, and then be really selective. So in some patients, yes, there can be a role of tendon transfer, but we have to be very careful and selective, because we do not want to overcorrect a deformity by transferring the one only muscle which was working to some other place and lead to another deformity. So you have to be very careful and selective in these children. Hence, having a clinic like these with multiple brains working on them together gives them a much better hope and chance, because it is a collective thought process, and we can overall give them a much better outcome in the holistic sense, instead of all of us just focusing on our individual points.
Okay, so one more information I want to share with a huge audience which is present here. In the order of presentations, Sumit presented first, because most of the children with spina bifida present to a neurosurgeon, and then they have orthopedic deformities. But I want to tell everybody that there are some occult or hidden or suspense spina bifida which actually present as an orthopedic problem first. And when you evaluate, they turn out to be having a neurosurgical problem. Yes. So, this is a message to everybody. If you see a teenage boy with a cavus foot, if you find a child who has pain in both lower limbs, at age of 9 or 10, these are indications that these are the children who may not be having actually an orthopedic problem, but this orthopedic problem may be a pointer to what is known as spina bifida occulta. If you have a child who has just a tuft of hair at the back, that tuft of hair at the back must be maybe a signal of something more serious which is inside, which is in form of a split cord or a tethered cord. And unless it is investigated and treated well in time, it can lead to urinary incontinence and progressive neurological issues in a child. So that's one more sort of a role of a clinic like this, to treat children in growing ages where a growth of the spine sort of gives rise to suddenly revealing symptoms of an occult spina bifida. And we have together treated many children with those issues. Sumit, you want to say something about it?
Sir, I just like to add on.
Please do that.
That was an excellent message, which I also wanted to point out, because that people really need to understand. It is not just the big swelling which comes in the spine, which everyone can really see. There can be hidden things as well. So similar as you said, there were recently last 2 months, I think there were 2 or 3 cases, even Sumit will remember. One, the child just came to me just for leg length discrepancy. The child otherwise seemed absolutely normal, but on proper examination, we found that the child had tuft of hair behind, and eventually that child ended up having surgery which Sumit operated. So that we found out, otherwise that child was just told that that hair can be shaved off later and just left alone. And similarly, there was another child who had just cavus feet, otherwise absolutely normal. We found spine MRI done, again he had some issues. So otherwise these were innocuous things which people had just left alone. But on proper examination and with the team, we ended up finding them and making them much better.
So Sumit, what are the red flag signs for spina bifida occulta? What should a pediatrician or a general physician look for, which could be having a potential spina bifida?
Sir, very, very good point that you had raised over here. I think occulta is much, much more common than the aperta with the open swelling. And last 2 months, Avi is saying, I remember 6 patients that I've operated in last 2 months that have been referred from the orthopedic team itself. Typically, patient with inturned foot deformity, patients who are toe walkers. Avi, one of the patients was toe walker.
Yes.
Patients who have a deformity of the tibia also. Patients who have only dribbling of urine, increase in frequency of urine. The earliest sign can be just increase in the frequency of urine also. It can be frank incontinence and everything, but they are looked up much earlier. But the soft signs are very, very important for a clinician to pick up, which is why we have a pediatrician in our team also, that who can direct a patient to an appropriate person. All these kids, we say, Dr. Avi is already doing it, Dr. Taral is already doing it. We should do an MRI to rule out neurological cause before we go for the foot deformity correction or those kind of things. And 6 patients in last 2 months. Right now, we are averaging about 200 spina bifida cases in over a year, which is, I think, one of the largest number we are going to be in India very, very soon, hopefully. And thanks to support from all the members of the team who are picking up what needs to be picked up at the right time.
So one more sort of suggestion and a clinical tip I have is, whenever you're ordering MRI for a suspected case of spina bifida occulta, don't just restrict yourself to MRI of the lumbar spine. Yes. Do MRI of the whole spine, screen the whole spine and the brain also, because there may be split cord, some other problem, hemivertebra somewhere else, and you will miss it if you restrict your MRI.
Yes. Well, thank you all. I think all these were very, very relevant points, and let's carry on. We've got 2 more specialties to cover.
So you have muted yourself.
Can you see my screen?
Screen is not yet seen.
Okay. Okay. So, we've seen how orthopedic surgeons are sometimes people who first see a child with spina bifida. Most often it's the neurosurgeons who see the spina bifida aperta. Either which way, a lot of children with spina bifida have urological problems. And so the role of a urologist in spina bifida is also very important. Now, it used to be thought that children who walk normally after a spina bifida surgery may not have any issues to do with the urinary bladder. But that's wrong, because almost 90% of children will have some issue or the other related to the urinary bladder. And why are there urinary symptoms in spina bifida? It's because the bladder is not in the control of the brain. And this will manifest as either urinary incontinence, urinary infections, and in severe cases, you can also lead to a situation where the child will have renal failure if he's not looked after. So all this needs very careful monitoring from birth. Now, when we were medical students, or even before that, when spina bifida and its treatment was in the nascent stage, one of the pioneers of spina bifida had described a patient as a paraplegic, incontinent cripple snatched from the jaws of death in the neonatal months, only to be delivered over to a tragedy of an expanding head or to a life of social exclusion in the fumes and filth of double incontinence and trophic ulcers. Now, very unfortunately for a lot of our children who come from some smaller towns or faraway places, this is still the situation where the treatment of stool and urine incontinence is not looked at carefully. And the aims of therapy, of course, are to keep the child dry, but more important, to prevent urinary infections, and in severe cases, to prevent renal damage, which can be the consequence of non-treatment. Now, what do we do with a child with a neurogenic bladder? We will do a little basic blood workup. We will do an imaging of the urinary system. We may do a cystoscopy, and there is another test called the Urodynamic Assessment. So doing an ultrasound will help to tell us what the bladder looks like and whether this bladder has affected the kidneys at all. This gives us a good clue, and we follow it up by doing a micturating cystourethrogram, which sometimes tells us how the bladder looks, how the bladder is behaving. Some of these bladders can be very rigid bladders, which are what are called non-compliant bladders, which lead to very high pressures when they are filled with urine. And this pressure is then transmitted to the kidneys, and this can cause kidney damage. We sometimes will do a urodynamic assessment, which is an examination by which the pressure and volume data of the urinary bladder can be obtained, and the urine flow, if possible, can be measured. And this has two components: the cystometry, which is the assessment of the bladder and bladder pressures, and a uroflowmetry, which is to actually see how urine is flowing out. And it gives you information about the bladder capacity, the pressures, and whether there are any sensations or not, which very often are absent in these children. And it tells us a lot of things which help us to get a very clear understanding of the behavior of the urinary bladder. And it helps us to monitor treatment and to change the therapeutic measures when they are not working very well. Also, pre and post-operative surgical assessment, especially before they undergo neurosurgery, is important, because very, very rarely doing a neurosurgical operation itself can change or it can affect bladder function. Sometimes you may get a slight improvement in the bladder function, and it's important to assess both these before and after surgery. So we have a good urodynamic machine at our hospital, which is actually state of the art, and we can do all these assessments for our patients. And very broadly, the therapeutic options that we have as far as the urinary system are concerned are teaching the parents how to modify their voiding patterns and their lifestyle. We may sometimes give them certain drugs to help to control, bladder contractions and incontinence. We may do something called clean intermittent catheterization, which is like the mainstay of treatment of a neurogenic bladder and spina bifida. Here, first the parents and later on the child are taught how to self-insert the catheter into the urinary system to drain the urine every 3 to 4 hours. And finally, of course, we have surgical options. Now, CSIC, clean self-intermittent catheterization, was a big breakthrough in the treatment of a neurogenic bladder. What is CSIC? C is clean. Clean means not sterile, but with adequate hygiene, something with which patients and parents, even in small villages, can do with very effectively. It's a self-catheterization. As soon as the child is independent, he learns how to catheterize himself. It is an intermittent catheterization. Keeping an indwelling catheter is now something which is not advisable, because the bladder doesn't fill and empty, what is called cycling of the bladder. And generally, we advise them to do an intermittent catheterization every 4 to 6 hours. And inserting this tube and allowing the bladder to drain out the urine completely is something that will prevent infection and will help to achieve continence. Now, these are two pictures of little boys who are not very mobile, who are actually kind of using these little stools with wheels to be ambulatory, who found a clean space under the sink in the public bathroom of their school to go and catheterize themselves in the break. So this sounds very challenging, but children learn this very fast, and they learn that just like other children go during their school break to go and void, they must go during their school break to go and catheterize themselves and empty their bladders. So the big advantages of a CIC are that it decreases infection, it decreases pressure generation in the bladder, and it saves the kidney damage. It actually also improves the growth and the function of the bladder and improves bladder compliance. The patient benefits are better control over their urine. There's no smell. There are fewer pads and diapers. It allows social interaction, allows travel, better hygiene. I remember one of the first few children whom I tried CIC on came back with her mother so ecstatic because she had actually managed 3 hours of dryness to go and watch a movie. In severe cases, we offer surgery in a neurogenic bladder, and this surgery is done when there is failure of conservative therapy. It can be for convenience, and it is something that saves the kidneys from infections and damage. The principles of the surgery are to restore the capacity and compliance of the bladder through help to achieve complete control. And in an emergency, even in small children, sometimes we do it when CIC or catheterization is just not going to be possible. Then we help to divert these children temporarily. This is it from the urological standpoint. Now, a very, very important component of spina bifida care is rehabilitation, physiotherapy, and all that happens outside of the operating rooms. Most children, or every single child, should go through an assessment by a rehabilitation specialist. And we are extremely fortunate that our hospital has a sister institution, which is the SRCC Institute, with an excellent rehabilitation team, which is headed by Nisha Agarwal. And I will invite Nisha to come and share her experiences of spina bifida with us.
My screen is, can you see my screen? I did that.
Absolutely.
You got my screen?
Yes.
Okay. Let's see now.
Do a slideshow.
Yeah, no, I want to just see I'm not muted or. Yeah. Yeah. Good afternoon. Good afternoon, everyone. We at Rehab are, very excited to be part of this clinic. It's as the doctors ahead have mentioned, that rehab forms a very important aspect. We actually get to do the fun part. When the child has been put through pain under surgery and everything, then we get to do the fun part, which is where we try to restore function and make sure that this child gets to, we address the 3 domains that Dr. Amrish mentioned earlier and provide a holistic approach. So our aim is to improve the quality of life and independence level of the individuals. The process begins from the neonatal period and lasts, unfortunately, can last a lifetime. The main principle is to prevent any complications depending on what level and at which stage the child comes to us. Other problems such as obesity, early puberty, and learning disabilities cannot be ignored, especially as the age advances. Our goal is basically functional independence, because any child that comes to us, their main goal or their main request is to be independent in their ambulation. And that's where we work towards providing whatever we can. Now, traditionally, this is what was done, which is physiotherapist who would work on balance. She would work on ambulation and the level of independence in gait training. Then we would have assistive aids. As you've seen the subsequent videos and rather the videos that were there earlier, a child that has spina bifida unfortunately has to will undergo and will go through a range of these prosthetics and orthotics throughout their lifespan. And depending upon what level they are, their level of ambulation could actually start with these orthotics and may end in some form of crutches or a wheelchair. And that is what we work towards. And then occupational therapy, which is also one of the old conventional therapies, which is where they work on activities of daily living. These are some of the orthotics, depending on what the child needs. At SRCC, we have a full-fledged prosthetic and orthotic department, and we are able to cater to all needs, starting from SMOs to AFOs to hip, ankle, knee, foot orthotics to wheelchairs to spinal jackets and so on. So the goal of the clinic, like the message that has been sent here, is that everything is under one roof. Now, some of the new form of therapies that are available is aquatic therapy, which again, we have it at SRCC. And this is therapy that takes place in a pool. This besides improving flexibility and using water properties of buoyancy and hydrostatic pressure and working against gravity or with less gravity, with gravity, we can get very good results. And we offer this at our center as well. And we also have this unweighing harness system, where we basically provide the support because the child or a older patient, if he is detected much later, has no lower extremity control. But providing this harness, we can simulate some sort of gait and movement and give them some hope that this is possible as well. Now, some of the other things which are very important and go back to the domains that we had talked about earlier is behavior therapy, family counseling and support, upper body strengthening, and nutritional monitoring. Besides the traditional OTPT and orthotics, these are new players which again are all offered as part of their rehab program under one roof. I don't think that's the last slide. Sorry, I also have a case presentation, and I'm going to just do that one. What can you see now? Yeah. This is a resume share. Okay, now you can. Sorry, this is not coming. No. One second. Resume share. Sharing is paused. Wait, I think, you know what, 1 second. Sorry, 1 second as I move to another one. This is there. Okay, I have to close this one. Okay, and now, yeah. Share screen and yeah, thanks. Okay, and slideshow. So here's a case presentation. A 1 year, 7 month female child came to us, and she joined us in August 28th. And I just thought it would be interesting for you to see what all we can do in rehab and what all we're doing for this child. So she has a diagnosis of meningomyelocele, GMFCS level 2, which means she's able to maintain a sitting position independently. An unruptured sacral MMC was detected at the time of birth, and she was operated on day 23 of life. She's had 2 sessions of rehab, and then she was referred to us in August and now has undergone 3 to 4 sessions. Her cognitive skills and her gross motor function skills were As you can see, she was able to crawl and pull to stand. Dermatomes were present till level 3, which means she had some, sensations up to level 3. Myotomes, we were able to get some knee extension and hip flexors and knee extensors, no ankle movements. This is how she came to us, only knew how to sit, and here's a as you can see, cognitively, these children are, within functional limits. And that's why, the concept of behavior therapy, family education, all this becomes important so that the child can understand that they can achieve, ambulatory status or being functionally independent or achieve some form of independence. Our plan of care involves sensory stimulation, core strengthening. We'll be offering aqua therapy to this child, orthotics, and as you can see, we've already started with the below knee orthotics for this child. And here is one session of hers. This is, a very feel-good factor when the parent sees that the child is able to do these things and achieve some sort of, normalcy. Thank you.
Thank you, Dr. Nisha. We were going to show you a video of one of our success stories of a child who was handled in our Spina Bifida clinic, but I think we are running late, so we've sent you a link. Do go through that YouTube video. This child had come from a small village in Uttar Pradesh and came to our hospital, and through our holistic management with all our different specialties, I think we've achieved something significant for this child. Our clinic doesn't stop there. We have counselors. For instance, I have a few patients whom I've treated very long ago who are now young adults, and they keep coming back when they are in relationships to figure out what the future holds in store. And I think having them speak to a counselor, speak to a psychologist, speak to other specialists is what we aim for at this clinic. One final thing that we are aiming to do is to get an adult specialist, because once they reach adulthood, we need to hand them over. And so we are in the process of starting transitional clinics with adult urologists and adult orthopedic surgeons who can take on with our initial care as children for these children as they reach adulthood and continue their care, which will go on lifelong. So thank you very much for your attention. And I hand over to Avi to invite the next group of people.
All right. Thank you, sir. That was an amazing discussion, and once again highlighted all of the important work that has been going on at SRCC through all of our multidisciplinary clinics. So now I'd like to invite the next multidisciplinary clinic, which we are going to talk about, that is ICANN, where we are going to talk about the multidisciplinary approach to improve health and nutrition for children. So I'd like to invite our senior pediatric medicine consultant, Dr. Paresh Desai, who will be moderating the session for the clinic. Sir, are you there?
Yeah, I'm there. I hope I'm audible.
Yes, sir, you're visible and audible.
Good. So we have this ICANN clinic, which stands for Improving Children's Activity and Nutrition. And this is for our children of pediatric and childhood obesity. We have pediatricians, pediatric endocrinologists, nutritionists, psychologists, all part of the team. And this multidisciplinary, because we all know that this pediatric obesity is right there in our face. We see it all the time, but we are not doing anything about it, or we are failing to do anything about it. And when we try half-heartedly, we sometimes give up and it's all over again. So therefore, to begin with, let me invite Dr. Mahesh Balsekar, who will introduce what we do here and take over from there.
Paresh, can you see my slide?
Yes, sir, your slide is
Yes,
seen. You can
everything seen.
Just make it full screen.
A warm welcome to everybody. Today we shall be talking about the ICANN program, Improving Children's Activity and Nutrition, a multi-specialty OPD which we have started at the SRCC. Now, if you see in the past, pediatric illnesses were dominated by malnutrition and infectious diseases. But the trend has changed, and now lifestyle diseases are likely to dominate the current generation of children, of which obesity is the one which is most prominent, and it's common and it's increasing. Unfortunately, treatment is ineffective, and therefore prevention is critical. If you want to prevent obesity, like any other disease, early diagnosis is important. And for an early diagnosis, the role of general pediatricians and general family doctors is extremely important. But what is important to note is that merely labeling a child as being overweight or obese is not enough. Because if you simply label a child as being overweight or obese, you do positively harmful consequences because the parents don't know what to do. They start very restrictive diets, and constant taunting can damage their self-esteem. And this is the reason why specialty clinics are very important, and they do improve outcome in the management of obesity. Now, I'll be talking about childhood obesity, that the prevalence is high. We'll see how there are rising trends all over the world. We will see that there is a disproportionate rise of obesity in low and middle income countries. And that if you have obesity in childhood, it's likely to result in obesity when these children turn into adults. Now, this slide tells you the worldwide prevalence of obesity. And what you see here is that there's almost a twofold increase in the percentage of obesity between developing and developed countries. You also see there's almost a twofold increase in the percentage of obesity between childhood and adulthood. So what this means in practice is that as children get into adulthood and as countries turn from developing to developed countries and the disposable income goes up, the rise in obesity is very dramatic, with a result that currently 39% of the people in the world are either overweight or obese, and this amounts to almost 1.9 billion individuals. Now, the Indian data again corroborates the same fact, and the Indian Journal of Pediatrics has reported a meta-analysis where they've shown that the overweight percentage is 12.6% and obese is 3.4%, so total almost 15%. Other studies have shown the prevalence to be substantially higher because the selection of the patient population is very important. The largest study, which was the WHO collaborative study, has shown that the percentage of obesity in India is substantially higher. If you look at the Indian data, the difference between the upper income and the lower income group is quite dramatic. And what you find is that overweight between government schools, which is low income, and private schools, which is upper income, the incidence goes up almost 5-fold. Similarly, in older children, it goes up almost 4-fold. Also, obesity goes up almost 5 to 6 times in both the age groups. So this means that as the disposable income goes up, the percentage of obesity is rising very dramatically in India. As the income goes up in India, we might see the percentages which are actually seen in USA. And more than 85th percentile means overweight. The percentage is almost 26 to 40%. And obesity is more than 95 percentile, which is almost 13 to 20. So these are extremely frightening figures. And morbid obesity, which is more than 99 percentile, is almost seen in 2% and almost 7% of adolescents, which is really quite having catastrophic health consequences. What we have seen is there are rising trends the world over. And between 75 and 2016, in girls, the percentage of obesity has gone up almost 6 times. And in boys, it has gone up almost 7 times. The good news is that with intervention, things can change. And while between 80 and 2014, the percentage of obesity went up dramatically to almost 20% in children. After Obama's presidenthood, where they had a big campaign called Let's Move to Arrest Obesity, we found that in school children, the percentage actually plateaued. And in preschool children, the percentage has actually fallen. So this does mean that public policy and intervention can make an impact in the long run. In India, a large study again by Ranjini, almost 750,000 cases, the percentage of obesity has gone up from almost 9% to 17%. So there is a dramatic increase in the percentage and there is a dramatic rise in the number, and the absolute numbers are extremely high for childhood obesity. Now in India, what we find, as in all low-income countries, that we have the twin burden of malnutrition and obesity. And on the one hand, you have malnutrition with a large number of children who are stunted, a large number of children who are wasted, and they suffer from complications in the perinatal period and infectious diseases. And on the other hand, we have a large number of obese children, particularly under the age of 5 years now, which is going up from 40 million and projected to be 70 million. And what is unfortunate is that almost 50% of the new obese children are in Asia and 25% in Africa. So while it is plateauing in the developed countries, it is rising very dramatically in Asia and Africa. And all these individuals are going to be seeing non-communicable diseases, that is diabetes and cardiovascular diseases. And this epidemic is likely to hit India in the years ahead. Now, if a child is obese, is the child likely to be obese in adulthood? And this is called tracking. So if you have severe obesity, almost 80 to 90% are going to be obese as adults. If there is a family history, almost 80% are going to be obese. If the onset is under the age of 3 years and you have rapid weight gain under the 6-year age group, then almost 90% have obesity. And if you have adolescent with obesity, almost 65 to 75% persist in adulthood. So this means prevention in childhood is extremely important, because if you become an obese adult, treatment failures are very high. So the window of opportunity to prevent this epidemic of obesity and lifestyle diseases really lies with the pediatricians. And that is why we have started this clinic called Improving Childhood Activity and Nutrition. And we have two approaches to this problem. That if you have a child with a severe problem with multiple complications, then they are referred to the multidisciplinary clinic, where the patient is evaluated by an endocrinologist, a pediatrician, a nutritionist, and a psychologist, and they're assessed extensively for comorbidities, metabolic problems, genetic issues, etc. The package involves 3 follow-up visits after the initial consultation. If the obesity is not severe, or a pediatrician or a physician has seen and feels that they don't need the advice of endocrinologists or pediatricians, then you can send them directly for what is called the nutrition package. And here the patients are seen by a nutritionist and the counselor via an initial consultation and 3 follow-up visits over a period of 6 to 8 weeks. The clinic is physical, but we are trying to make it online and subsequently hybrid. So this has a cost advantage, because when you have a package, the cost is substantially lower. The patients are seen in one visit, so it saves time and improves compliance. And most important, when they have a holistic approach, then the outcome of these children is substantially better. Thank you. Paresh, carry on.
Once this topic has been introduced, I hand over to Dr. Prashant Patil, our pediatric endocrinologist, who will elucidate on the what really is happening here. Prashant.
Yes.
Yeah.
So can you see my presentation?
Yes, you are very much visible and present. Yes, go on.
A warm welcome to today's audience. So I'll be discussing about the new childhood obesity, like how exactly one should define, and most importantly, when the childhood obesity should come to us. So as rightly pointed out by Balsikal sir, that we are living in the modern obesity epidemic. And when we talk about the childhood obesity, is roughly divided into two arms. One is your nutritional or simple, or what we call it as a idiopathic obesity, which by the way, not so simple to treat. And the other spectrum, which is less common, that could be your endocrine obesity. It could be a genetic obesity or monogenic obesity. So nutritional obesity, which we seen in rampant, which is almost 90 to 95% of the cases which we see. Less than 5% of the cases where you could have a hormonal affection, like it could be a hypothyroidism, it could be a hypercortisolism where there is a steroid excess, it could be iatrogenic because of the drug induced, specifically the steroids, or very rarely there's a spectrum called monogenic obesity, which is present in less than 1% of the cases, where particular gene which is involved in energy metabolism, it is mutated. So which is classically seen in infantile obesity or less than 5-year-old children. So basically, I want to make it easy for the pediatrician or the general physician that all we need to divide is into these two arms, whether you are treating a nutritional obesity or you are vis-a-vis you are treating maybe a genetic or endocrine obesity. Now to define obesity, there are criteria for which is could be a WHO or a IOTF. So for up to 5 years, and it is important to know that up to 5 years, we do not use body mass index to define childhood obesity. In fact, we use weight for length. And if your weight for length is more than 99 or more than 99.9 percentile, then we call it as that particular child as obese. Now, what it means that during the initial 5 years, we have very high threshold to call someone as obese. So highlighting the same thing. So if you're seeing a child whose weight for length is going beyond the 99.9 percentile, that means there is something grossly wrong and you have to refer those under 5 obesity surely. I'll be showing those growth chart, and with the help of IAP growth chart, we can easily diagnose who are overweight and obese. Now, during between 5 to 18 or 5 to 19 years, as per the WHO cutoff, we use BMI percentile. If you're more than 85th percentile, you are overweight, and if you're more than 95th percentile, then you are obese. But this definition somehow doesn't hold true in Asian context, because as we know, we are a short and obese population. We have a lot of fat as compared to our white counterparts. So we generally should have a much low threshold to define obesity. So what International Obesity of Task Force has defined, that overweight should be defined when your BMI is crossing more than 23rd adult equivalent, and obesity should be defined whenever your BMI is crossing the 27th adult equivalent. So not 25-30, but it is 23rd and 27. And it is available on your IAP growth chart. On the front side, you have height and weight, but on the flip side, you have these BMI chart. Now they are color coded. If you see up to 50th percentile, it is color coded as black. You can say this is as a safe zone. The moment your BMI crosses this orange line, you are overweight. The moment it is crossing this red line, which is 27th adult equivalent, so it is obesity. And these are the charts which is readily available. It is also easily downloadable from IAP website. And I insist that everyone, those, if you are assuming that the particular child that you are seeing is maybe overweight, I assure you that if you plot them and calculate their BMI, they will be well above than 27th adult equivalent, and they will fit the criteria for childhood obesity. Now, just to highlight the same criteria, how to define the nutritional or differentiate between nutritional vis-a-vis pathological obesity. Now, this is a 10-year-old child having the same sort of BMI, but there are two sets of patients which you come across. The first case, where the weight was around 33 kg, but height is 120 centimeter. For a 10-year-old child, this is relatively short. The other case where the weight is around 50 kg, but the height is absolutely normal, around 145 centimeter. So you can roughly say the second child is tall and obese, where the first child is a short and obese. So when we try to plot his weight age and height age, the height age of the first child is around 7.2 years, where the weight age is approximately 10 years. So what you can see here from the first case, that your height age is affected much more as compared to your weight age. So this is classically your pathological obesity or endocrinological obesity. Vis-a-vis, if you see on the right side of the second case, where the height age was 11.9 year and the weight age was approximately 14 years. So here, the weight is affected more and you're tall. So if you're short and obese, it is a pathological or endocrinological obesity. And simply by plotting on the growth chart, if you see that your child is tall and obese, it will simply define a nutritional obesity. In the first case, this was classical case of hypothyroidism, untreated hypothyroidism, where TSH was more than 100. So all we need to do is start them on a thyroxine. So highlighting the same point, I'll just show you that less than 5% of the cases which we see rarely as monogenic or endocrinological obesity. So this is 1-year-old child with birth weight of just 2.8 kg. There's a significant weight gain since age of 1 month. She was developmentally okay. She was born with normal birth history, full-term normal delivery. So this was a classic case of monogenic obesity with leptin deficiency. The treatment is subcutaneous leptin injections, which is unfortunately not available in country. Another case is an 8-year-old child, again short and obese on the growth chart, had a retinal changes, retinitis pigmentosa on fundus examination. She has polydactyly has been highlighted. So this is a classic case of Lawrence Moon Bardet Biddle syndrome. So again, an example of syndromic obesity. This 10-year-old boy, again short and obese. You can see his eyes classically almond-shaped eyes. He had micropenis with undescended testes. This is nothing but your Prader-Willi syndrome. So you should be able to identify those less than 5% of the cases, and you have to be extra careful in telling them the dietary goals as well as the interventions. Some of them, they do need a special drugs. So this is again a 6-year-old girl, again short and obese. You can see the moon face and buffalo hump. This is a case of exogenous Cushing syndrome where she has been wrongly prescribed prednisolone and she has continued for more than 1 year. So this is a iatrogenic Cushing syndrome. Now, why we need to worry about obesity really? Because obesity is a multi-system disorder. It can affect any of your system. Most importantly, it can lead to a metabolic syndrome, which is a cardiovascular dysfunction, can lead to a dyslipidemia, hypertension, and type 2 diabetes at a later age. In gastrointestinal system, it can produce a non-alcoholic steatohepatitis. We are seeing a lot of surge of NASH in recent time, probably because we are doing more and more investigation with increase in the blood sugar level. We as well. Also with increasing weight, you can see a lot of orthopedic problems like blount and slip capital femoral epiphysis. So all in all, it can lead to a multi-system affection. So that's why we have to treat and rather prevent it, as Dr. Balsekar has said, because treatment is rather ineffective. Now, when we screen those individuals who fits into the obesity spectrum, we should screen them for the complication, because when we see a child who is frankly obese, we divide it into two spectrum. Those who are obese child but without any complication. The second arm is obese child with complication. So in all obese children, you should check their fasting sugar. If their fasting sugar is more than 100, then you should ask for oral glucose tolerance test ideally. If not possible, then HbA1c. To diagnose non-alcoholic steatohepatitis, you should ask for liver function with SGOT and SGPT. Any rise of 4 or 5-fold in SGOT lipid profile, and you have to be absolutely worried, just like in adults, but we are more hypertriglyceridemia in children. We also have to screen them for the hypertension. So clinical BP measurement at every individual visit, it's crucial. If you're seeing a girl who is having hirsutism, then suspect polycystic ovarian disease. Check her male hormone, that is serum testosterone. If the values is going beyond 50 or 60 nanogram per DL, then probably it is diagnostic of PCOD. Also, those individuals also prone for obstructive sleep apnea, and you can do a polysomnography in such case to diagnose obstructive sleep apnea. Now, whenever we are seeing a child with fasting sugar, which is more than 100, you should ask for oral glucose tolerance test as per ADA recommendation. Please remember that HbA1c is not the ideal test to diagnose impaired glucose tolerance or type 2 or a type 1 in pediatric age group, but it is the oral glucose tolerance test which will diagnose the impaired glucose tolerance in pediatric age group. So all we need to do is you have to give them 75 grams of anhydrous glucose and check their serial samples of blood sugar every 30 minutes. The moment your levels are between 140 to 200, it is known as impaired OGTT. And the moment it is more than 200, even a single value out of these 5 values is going beyond 200, then we call it as a type 2 diabetes or the provisional diabetes mellitus, and they need a lifestyle modification along with oral hypoglycemic agents. Now, importantly, when should we refer these cases to the pediatrician or to the endocrinologist? Whenever you are seeing a child who is obese and the obesity has started during first year or initially first 5 years of life, then you have to be extremely worried. When your obesity is associated with special senses affection, that means eye affection or hearing problem along with developmental delay or mental subnormality, these are the cases probably this indicative of monogenic or syndromic obesity. So this needs certainly needs a referral. One marker of insulin resistance is acanthosis nigricans, as you can see from this diagram. These are insulin resistance sign which is present on the flexural aspect and the nape of the neck. This tells you that they have a higher propensity to develop a metabolic complication at later age. Whenever there is a history of diabetes mellitus, hypertension in family, you have to be worried. And if one of the parents of your child is also obese, then also you should refer, because this could be a spectrum of nutritional vis-a-vis genetic obesity as well. So to summarize, I'll say that one has to understand what should be the nutritional and how to differentiate between nutritional and pathological obesity. Use your Indian IAP growth chart to differentiate between overweight obese and obese on a particular child. And whenever the obesity is coming before 5 years, especially during first year with special sense affection, you have to think about monogenic obesity. So thank you so much. Over to you, sir.
Yeah. So coming to now once we know that there is an obesity and now we know when to refer, we've also understood what to do when there is a obesity which is like really a problematic thing. Then most of the obesity that we are seeing are actually not the endocrine obesity and the Prader-Willi eyes and the Lawrence-Moon-Beadle syndrome, but this is absolutely simple obesity caused by the diet, the environment. And I just want to give you a very brief idea of how to prevent and why it is so important to prevent obesity in children. And once you do have an obese child, what are the goals and how do you set them? So the main reason is that you have to prevent adult obesity. You can't have a child who's obese and then go on to become, as Mahesh said, tracking into an adult with obesity and all its complications. Reduce the long-term complication, blood pressure, hormonal issues, heart disease, non-alcoholic fatty liver disease, which is going to be the most common reason for liver transplant 3 years from now, and not the cirrhosis that we see now. Identify children who are predisposed to adolescent and adult obesity, treat them early, identify intervention in the at-risk child, again the same way, and assess the long-term risk of obesity in the predisposed child. This slide looks a very busy slide, but really speaking, what it says is this is the child weight status. And what are the factors? Child characteristics and child risk factor, gender, age, the lifestyle, sedentary or an active lifestyle, dietary intake. These are the two main things, how much you eat and how much you spend. And then the family susceptibility. Then you go to the parenting, which is the next big circle. Child feeding practices, what are the foods available? Do they have a knowledge of nutrition? What do the parents eat? What are the things available at home? What is the socioeconomic status? What is the parent encouraging the child to run about, play, or just sit, have a sedentary? How much of parental TV time is there? All these things, and the interaction with other siblings. And then the whole community. What race you belong to? Are there school lunch programs? Do you eat lunch in school? What are the working hours, leisure time? What recreational facilities are really available? Do you have playgrounds? Do you have games? Does the school have a lot of physical activity or no? Is it safe to send your child outside to play with crime rates and so on? So, all these factors affect these things. In prevention, when you go, it is basically the most important thing is finding out. And therefore, like Prashant said, not just height, weight, but a universal measurement of BMI, and plotting it on a very easily available BMI chart will tell you where your child is headed. And it's extremely important to find out. So they should be routinely assessed for obesity-related risk factors, that is obesity in the parents and family, means they are eating the same food. What are the dietary habits that they have that promote weight gain? What are their physical activity habits? Sleep. Lack of sleep, late nights are very, very conducive to development of obesity and wrong eating habits. When you're counseling these people, you have to do assessment, you have to give them goals, you have to give them tips. So what is the family eating environment? You're all sitting in front of the TV, and looking at meals and not even knowing what you're eating unconsciously, like how you eat popcorn in a cinema. You don't even know how much you're eating and what you are eating. Or are you being fed by a mother or a caregiver or a grandmother? The child doesn't know satiety. These are very important things. Are there diverse diet and meal-based eating? Or is it just sabudana khichdi and halwa? It's like that. Or is there a salad? Is there vegetables? Is there pulses in the diet, grains? You have to limit food that is available with very low nutritional value, and identify the obstacles to good management. That is the habits of frequent snackings, lots of snacks available which are not so healthy. You have the picky child who eats only one kind of food and then nothing is being done about it, which can lead to problem. And if the role models, in which case the siblings, the peers, the adults, the parents, if they are eating the wrong kind of food and all, it's going to have an effect on the child. Physical activity, you have to limit screen time, which means internet, TV, video, pods, and so on. Whether the physical activity unstructured. So little children who are below 5-6 years of age will have unstructured. They run about, play, cycle. And when they are bigger, you have football, cricket, and other kind of games. But there should be a lot of that. And this should be encouraged. And a normal sleep time. Now with the pandemic, even the sleep thing has gone really out of the window. Everybody sleeps at midnight. I don't know what will happen when schools open and whether children will be able to wake up at 6:30 in the morning, because they're all used to sleeping late. Sleeping late means you feel hungry, you add added snacks, you get a lot of satiety changes, hormonal changes, and these are very conducive to obesity development. The approach should be practical and problem-oriented, taking into account what are the finances of the child's family, who are the caregivers. Both parents are working. Is it the grandparents? Is it a creche? Is it a caretaker? Is it somebody who comes in the morning and leaves in the evening? That kind of thing, and you have to take that person into confidence. Commercial programs that we have seen, where they take money and give you a 6-month program, are not very successful with children, because they don't see the point of all this. And you are actually just handing over your problem to somebody else who really doesn't care except for the money. And therefore, this is not going to work so well. When you set goals, they have to be smart. That means specific. You must specify what you want. They should be easily measurable. You must see the difference. They should be not impossible goals, attainable and realistic. And there should be timing. And it cannot be a goal which can last 5 years. That's too late. Contracting means involving the child, telling him or her what we can give you, making deals. Deals do not have to be food deals, but deals have to be something that the child likes, which is easy to do, so that there is some form of incentive and a positive reinforcement of even a little change, so that it goes a long way in continuing. We have specific nutritional goals in the form of structured meal and snack plans. Very structured meal plans, very structured plans don't work very well with children. There should be some flexibility, but the availability of what food is there is very important. So you have to limit the amount of, and in all our houses have chivda, sakkarpara, cookies, biscuits, all available right there on the table in burnies, in glass jars. That cannot work. You have to increase the amount of fruits, vegetable and fibrous foods that enter the house, and everybody should be eating that. So if there is very little vegetable made and lots of rice made and lots of other things made, then that's a problem. Screen, like I told you, screen time, device time. Now with the pandemic, everybody is on the screen anyway. But if you take out the school time, you must limit screen time to 1 to 2 hours after that. Otherwise, it's going to be difficult for the child to get. Moderate to with 1 hour of physical activity is a must every single day. And even if it doesn't show a quick weight loss or significant weight loss, it steps up the metabolism and the child gets better and better at the weight goals that we are going to. And we avoid the use of weight, fat, and we try to take terms like BMI so that the child doesn't feel castigated, or there should be no stigma. So we have to have motivational approaches to the reduction of the BMI. There has to be assessment of the family's level of readiness to change, because it is a whole family thing. It can't be a child all by itself. Like Ms. Clinton said, it takes a whole village to raise a family. A child and a family definitely has to be there. It should be non-judgmental. It should be empathetic. It's very difficult. So if you have a child who's 11 years old and 75 kilos, till he is 65, nothing will be seen. But, you have to work at being empathetic, encourage even the smallest changes. And you can't scare the child and the parents. Abhi to isko heart attack aega, diabetes hoga, this is that. So that will make the child run away from you. You emphasize on how that this child has to grow into a healthy adult who does not have heart disease, who doesn't have blood pressure, who doesn't have, issues with hormonal issues like bad periods, polycystic ovaries. When the child grows up, she'll be able to have children. There'll be no sterility and all kinds of issues. So you go on those goals, and that brings the parents to your side. There is also diet and nutrition, what is known as a DASH, because blood pressure is a very big complication. So you reduce the sodium, increase potassium, increase fresh fruits, vegetables, and low-fat dairy products in the diet. Activity, like I told you, weight reduction must, and you must tell the parents and the caregivers how it significantly reduces blood pressure risk, stroke, and diabetes development. And if you don't do anything about it, how significantly it increases these problems. And tell them that these habits that you are putting, you can program your child now, and will be lifelong habits, which is healthy eating and expending those calories in the form of exercise and physical activity. And that will turn a long, long way. Children who are 5, 6, 7, 8, 9, 10, we completely control what they eat. And therefore, this is a wonderful time to imprint good eating on your children. School-based intervention works very beautifully, because if the school is concerned about fitness and the school involves children in games, sports, group activities which are active, that also makes a huge difference. And there are studies to show that in bigger children, it really, really makes a lot of difference. Long-term reinforcement of nutritional goals, you must go on, that this is not something that stops at 1 year or 6 months. You know, I'm on a diet, my child is on a diet. There's no such thing. It's a lifestyle change for the rest of your life. You find out what are the social emotional barriers to this. You know, we say, "Bachche ko don't stop children. Let them eat what they want. Baad mein to there is a problem only. So let them eat. Bachcha ice cream, chocolate, cake nahi khayega, to kaun khayega?" But then that is a problem, because these are the children at this age when they are active, you can do something about it. As they grow and track into adults who are overweight, and you've seen the figures that Dr. Mahesh gave, they are frightening. Growth and pubertal development issues, reproductive issues must be seen and discussed with the parents. That, you know, really makes the child's parents perk up and helps them to come onto your side. Like Prashant said, glucose tolerance may have to be done. Impaired glucose tolerance might be found out. You know, you can tell them about cholesterol and stuff that can happen. Avoid blame when you're setting goals. It's your father's fault, your mother's fault, it's this. Don't do that, because it doesn't help. You have to explain that, you know, be nice, be kind. Say, you know, some children do get weight more early, and how genetics, social factors, environmental factors, the availability of so much mechanized transport, the fact that we don't walk to school and all that for various reasons. These are all factors, and we have to do something about it. Don't call it weight, BMI all the time. Don't call it fat all the time. You know, use terms which have weight, BMI, makes difference. Explain and emphasize how, when you're setting the goals, the whole aim is not just to make a child look good, but he should grow into a healthy, functioning adult, strong adult with normal faculties of reproduction, metabolism, and so on. Go on to BMI, look at the parental weight and get them also on a program, because you can't have children who are on this program with really huge fat parents who have had bariatric surgery. I have patients who have, the child is on the program, but the parents have had two bariatric surgeries. So it doesn't work. And concentrate and talk to them about the comorbidity, blood pressure, diabetes, reproductive issue, hormonal issues, acne, all these things that not only find them out, do something about them, but that will bring the parents onto your side. Child involvement has to be family involvement and investment. It's so important. Whatever the family is doing now for the child, it's like putting money in the bank and waiting for it to mature into a big deposit. And that's so important. The intervention should be non-judgmental. Don't say it is this fault. Like I said, empathetic, encouraging. Avoid pressure and criticism. Authoritarian parenting goes usually the opposite way. Children rebel and will only have chocolates. Economic factors, cultural factors, where the child comes from and hails from, also have to be taken into account, where the multidisciplinary system, the counselor and the nutritionist has a huge role. Thank you. I'd like to now call upon Dr. Haji, who will tell us about what is the psychological impact and what is the role of the counselor in the clinic. Sachi?
Yes, sir. I am just sharing my screen. Just give me a moment. Is my screen visible?
Not yet.
No. So you need to stop sharing. Yes.
Yeah, I'll do that. Okay, now, yeah.
Oh, is my screen visible?
Yes, it is. And you're audible. Go on.
Lovely. Thank you, sir. Thank you. And I think we all have had intense case discussions and, about the topics and a lot of information being shared. And as we begin about the subtle role that, a psychologist or a counselor plays in these clinics, I would like to give you a case scenario. Like there are all children. I mean, I don't know even one child who doesn't like to eat pizza or a burger or french fries. And there's this parent who tells this child, hey, you can't have this every day, you just can't order pizza out of the blue, and this is not healthy, you can't eat it. And there's another parent who sits with the child and discusses about the national foods, the international foods, and takes a quiz, and then collaborates with the child and decides, okay, there are certain days when we can have international foods. There would be Saturdays and Sundays when we would definitely have pizza, while on weekdays we would have roti, sabzi, some other cuisines, which are national foods. And the key to managing weight and preventing obesity lies in this. So weight management is not simply about reducing numbers on the scale. It's about how and what you eat, how and when you move, your activity levels, how you feel, and how you cope. And success often, therefore, is measured in changes in health behaviors, which are long-term, and improvement in overall physical and mental well-being, and the quality of life. Assessing root cause is very, very crucial, very important. And oftentimes, these causes are multi-layered, overlapping, and therefore we use this multidisciplinary approach. I would like to discuss cases that we are currently seeing in the clinic. SK is an 18-year-old female who appears enthusiastic, is an athlete, dreams of a career in police force, is very hardworking. And when she gave a recall of her routine, she was the one who was waking up at 5, doing yoga, eating meals on time. And, there were certain things which, on surface would look very perfect, but there were underlying issues that came up during the session. She was a victim of body shaming. She carried this guilt of being a burden to her parents. There was constant stigma that she was experiencing, and often her relatives and neighbors would tease her and tell her that, you'll not find a right match for marriage because of your weight. Her performance anxiety increased as she was not able to go for her practice, and her anxiety about selection in police force was like, a dream coming to an end. And she was experiencing extreme loneliness and mood changes. The question is, can these states become roadblocks to weight management? And obviously the answer is yes. There is this another child who is 10-year-old female. She loves to share, likes to make friends, but often withdraws, keeps things to herself, and feels easily tired, nervous. Definitely, there are underlying health reasons, but equally, underlying emotional and social aspects to their condition. We identified the following. The parental approach was authoritative. The child often feared upsetting her parents, and she built on this guilt that, right, my dad needs to scold me because I'm the one who is wrong. I'm the one who's making mistakes. I can't get anything right. There was this deep loneliness, sadness, experience of being bullied by friends, and poor peer support. How these could become roadblocks to weight management? Of course, the self-doubt and anxiety comes in the way of setting goals. The fear of being judged can get you into isolation and avoidance of seeking support. The fear of failure, low enthusiasm can bring down the motivation to even set goals or achieve them. And these problems can be perceived bigger than they are and can lead to, again, emotional eating and boredom eating, which could get them into the whole cycle of or loop of being overweight. So yes, the crucial goals here are improving child's body image and body size acceptance and helping them with how to do the things or how to achieve, set goals in the first place and achieve, then what to do. Most of the times kids know what they should do because parents and all their elders have told them most of the times, you should do this, you should do that. And they often come and tell me that, I know what to do, but how? That's where we come in the picture. So the clinic's approach is the 5 A's. Asking for permission to discuss weight. As Sir said, that weight is very sensitive, and oftentimes there is a lot of stigma, fear of judgment attached to this, and even using words like obese or you're overweight can get the child or the parent into a resistance space. Asking permission to discuss is very important. Assessing the root causes and advising them about the risk or discussing about what are the options is where the clinician's role is of utmost importance, where a psychologist and nutritionist come into picture. Playing a major role is in the further steps of helping children to set realistic goals, smart goals rather, and assist them in achieving those. So smart goals are specific, measurable, achievable, relevant, time-bound, and we also move forward from smart goals to smarter goals, where we add the elements of engaging with the child, collaborating with the child, and reviewing that how their goal setting approach and moving through this journey is further taken ahead, and again assessing the barriers that are coming in the way. So when we are doing this motivation goal setting exercise, it's about identifying what are the goals. Like we give them the space to write down their goals, where they can choose increasing their physical activity. Maybe they can say, I'm exercising for 30 minutes or 1 hour. I would like to do dance, or maybe I would like to do brisk walking, or I would like to play. It's their choice. Then we ask them why this goal is important to you. It's going to increase the energy levels, or maybe it's going to improve my sleep. So there are various aspects, not just the weight that becomes the motivation for the goals. And we also ask what could be the barriers that you think could come in the way, and who would be the person you would seek support from to meet these goals. And this is a in-depth exercise that happens during the clinic when they are with us. And I would say sometimes listening can be enough. Empathic presence, connection, collaboration, validation, that we know that it's hard for you and we can see that you are trying. Sometimes weight loss is not the goal that we are looking at, but even if they could prevent further weight gain, or slow down the weight gain, is enough for the moment till they take their journey further. And the nutritionist and I work in very close spaces with the child, where we help them with setting goals in terms of their nutrition and their physical activity, and also the most important, the space of their moods and how they are coping with their feelings. Again, bringing the parents in this space is very, very important. They are the main team members with the child, because without them, it would not be possible. And that's why I said that the key to managing weight and preventing obesity lies in the example that we presented earlier at the beginning. Thank you so much. Complete acceptance is the first step towards positive change, and reinforcing this that, hey, you're amazing just the way you are. There's nothing about you that we want to change, but the behavior that we want to change is very, very important. Thank you so much.
Thank you, Sachi. That was excellent. And we now go on to a chief nutritionist, Roshan Kore, who's going to talk to us about the nutritional goals, which is the other half.
Thank you, sir. It has been a long day and we are almost at the end of the journey with just 2 more presentations. Coming to the other half, like my better half was Sachi. She's done with her part of the counseling. I'm here to present a nutritional intervention case study for weight management. TJ, 8-year-old female with height of 130 centimeters and weight 34.5 kgs, had a BMI of 20.44 kg. Her weight for age was in the 92nd percentile, while height for age was 65th centile. So she kind of comes in the tall and obese overweight child that Dr. Prashant had explained. The healthy weight for height can be set around 22.8 to 30.9 kg for this child. A detailed, when the child was referred to us, we did a detailed screening, both on the behavioral level as well as the dietary screening. Behavioral screening revealed that the child often spends after school time indoors. She prefers quiet activities, often eats in front of the TV, frequently skips meals, always eats as much as an older sibling or adult, and usually request second helpings. So these are certain behaviors which we know are going to lead to obesity and overweight. Dietary screening showed that the patient was a non-vegetarian, ate around 5 to 6 meals per day, eats outside food once a week, eats desserts daily, multiple times, bakery products 2 to 3 times per week, and likes to eat foods like grilled chicken, dumplings, pizza, burgers, pastas, especially something which is ordered from outside. A detailed home diet recall was taken, which showed that the child was eating banana sometimes for breakfast, or sometimes it is combined with cornflakes or oats with a helping of milk, honey. Twice a week, she will eat an egg omelette. School snack is a combination of healthy and unhealthy, with dhokla or poha or upma as a breakfast item, along or a sandwich, along with some biscuits or cookies. Once in a week, junk food is officially allowed by the school, so she would end up taking biscuits, cakes, or brownies. School lunch is comprised of dal or kadhi with rice or paratha or pasta or noodles, or a Thai curry with rice, with a compulsory sweetened beverage and a dessert every day. Snacks around 3:30 is a helping of a fruit, or the day she visits her grandmother, it is dal and rice or a keema with rice or a aloo paratha, some heavy meal where the grandmother can show her love for the child. Around 5:30 to 6, she would have a snack comprising of dhokla or muthia or poha or a mawa cake. Dinner is a regular meal with dal and rice or roti with sabzi, salad, curds, and a compulsory portion of sweet. Groundnut oil is mostly used for cooking, and the child has a very sedentary lifestyle, not much play involved. The diet was prescribed, taking care that certain things which are good or healthy are kept the same way. When the diet was prescribed, it was taken care that the child's diet is not completely upturned, so that we can slowly and easily bring the child to make changes step by step in the diet, and it can be acceptable. If we completely change the diet, the child will be resistant to it and will not be able to adjust to the changes comfortably. So morning breakfast was kept the same, with just emphasizing the need to reduce the quantity of honey that was added. Milk option was given, can be changed to low fat. When eggs were had, instead of having oats or other food with it, 2 multigrain bread were allowed because the child loved to eat toast. School snacks was similar, with a healthy snack. Options for some sweet was changed to biscuits like Threptin Light and nuts or some dry fruits. School lunch was the same. Emphasis was given as to eat the same portion, but with same food with smaller portion size, and to change the preparation by adding more portion of vegetables to the preparation. For example, if pasta or noodles is to be prepared, one portion should contain at least half of vegetables and half of the pasta or noodles. Thereby, you can cut the calories and the carbs in the diet. Dessert, which was every day, was told to be reduced to once in a week, and also the portion size was to be reduced. Snack was replaced with a fruit or some light snack like popcorns or kurmura or makhana. The child has started, had suggested that she would start going to athletics. So post athletics at 5:30, a boiled egg and vegetable soup was advised. Dinner at 7:30 was given in the form of salad or grilled vegetables, since she liked to take the vegetables in that form, with a healthy portion of protein in the form of dal, curds, sprouts or pulses, and a small serving of rice and roti with sabzi. Sweet was advised to be restricted to once in a day. The child was counseled to avoid sweets, fried foods and junk foods, and avoid sweetened juices. The child was also counseled a lot about making certain behavioral changes in the day-to-day routine. A principle which is easy to explain to children is making 5-2-1-0 the goal for every day. So that means 5 or more fruits and vegetables, 2 hours or less of recreational screen time, 1 hour or more of physical activity, and 0 sugary drinks, more of water. Also emphasis on reducing the screen time, no screen time for the children below age of 2 years. So when we are explaining behavioral changes to children, we need to do it in their way, in a kid-friendly way. That is when we will reach their mindset, and we will make them understand how easy it is for them to make the changes. Also, we use different methods to make the child understand how they can change the diet. The stoplight diet teaches children proper nutrition by color coding foods. So high calorie foods are coded as red and are advised to be eaten only rarely. Moderate calorie foods are coded as yellow and can be eaten in moderation. Low calorie foods, including vegetables, some fruits, are coded green and can be eaten freely. So when the diet change is explained in this manner, the child is more receptive to it. As we have previously discussed, our previous speakers have discussed in detail about the goals. These are the kind of goals that we set for the chart. Like these are the charts we use to set the goals. So the counselor and the dietitian will sit with the child and help to set the goals. They will help to make the plan and get the child to work on it. They will help the child to stick to the goals and to reach the goals. And the most important job, the parents and the support team has to appreciate the good job done by the child, so that we can motivate the child to continue doing the same. Goal setting is done by having a chart where we have weekly goals. The counselor will sit with the child and discuss in detail why the particular goal is important to the child, what kind of confidence that the child has about completing those goals, how the child can track the goals, what are the difficulties or the barriers that the child sees in completing these goals, and what support might be needed for her to aid in the completion of the goals. These are a few examples of the goal sheets that our children have managed. So children write their own goals, they decide on their own goals, and the tracking is important. So we give them different options. For example, we see here a child is using smiley, a smiley face or a sad face is used to depict whether they have stuck to the goals or they have missed on it. They are encouraged to use stickers or flowers or different kinds of colors or just plain tick marks. So this helps to keep the child on track with the goals and keeps them motivated to do the work that has been assigned, as well as to keep the tracking of the goals. Coming to the follow-up and compliance of this child, the first follow-up was taken at 2 weeks, and it was seen that the weight was the same and the child was maintaining the same BMI. Compliance to physical activity was good. There was increased physical activity, almost double of what it was earlier. The child said that she felt more energetic. Compliance to diet was good. A few areas of concern were seen, like the child felt hungry, especially when the previous meal was not eaten properly. There was a few areas of improvement also, where the increase in physical activity was seen, decrease in portion sizes was done, increase in vegetable intake. The child was able to do monkey bars. There was better flexibility and muscle strength. And the mother reported that the child was more nimble. Suggestions given were that she continues with the previously set goals, because we need that give the child enough time to get used to the previous goals. And once set, the child can continue with the goals, and we change it only after the child is ready for the next leap. Week 4 was the second follow-up. We saw a slight increase in weight at this time, but the diet compliance to physical activity was very high. Some form of exercise was being done every day. Yoga, free play, gymnastic, athletics were some of the exercises or the activities that the child was indulging in. Difficulty with certain compliance to the diet, because the child had difficulty in restricting sweet. Also, she had difficulty in saying no to the junk snacks that were shared by the friends during the lunchtime, or which were brought in the tiffin. Also, areas of concern were need for a variety at breakfast and snack, and the water intake was inadequate. Areas of improvement: inclusion of physical activity, increased stamina, and more energy. Suggestions given were increase the fluid intake, and in the form of unsweetened beverages like soups, chas, nimbu pani. Suggestions for snacks and breakfast were provided. Child was told to follow the diet chart and physical activity as usual. Week 9 was the third follow-up. We saw a reduction in the weight to 33.7 kg. A regular exercise was complied to. Diet compliance was very good. Areas of concern was still the dessert, which was now 5 times a week rather than 5 times a day. Area of improvement: she enjoyed the physical activity, which was a plus as per me, because that is what will bring about the behavioral modification in the long run. Suggestions: follow the diet, continue activity, control the dessert portion, and replace dessert with dry fruits if the craving is very strong. Week 12 was the final follow-up. Weight had gone to 33.9 kg. Height was increased by 2 centimeters to 133, bringing the BMI to 19.2. So in total, there was a weight loss of 0.6 kgs, but the BMI had reduced by 1.2 kgs. So this is what we were trying to say previously also, where we do not emphasize on the weight loss in a huge number, or we do not emphasize on the kgs that are lost. We are happy to have the child stuck at the particular weight, but if the behavioral modification happens, the height of the child increases as the child grows, and the BMI normalizes as much as is possible. And the long-term behavioral changes will further help the child to come to a normal, healthy weight. So at end of the program, the child was doing physical activity 6 times a week. She had began athletics and swimming, and also gone on a school track, which she found very easy to do. Compliance of the diet was very good. Areas of concern were the dessert was 5 times a week, inadequate water intake. Areas of improvement: feedback from the teacher was received that there was increase in stamina and the child had developed good muscle strength. Suggestions were portion control for food, reduce desserts to 3 times a week, and continue the physical activity. So over the period of approximately 3 months, we saw that a lot of behavioral changes had happened in the child in terms of activity, attitude, and diet. And the child was gave us a good hope that she would continue doing the same changes henceforth also. So a goal without a plan is just a wish. So if you wish for one of your patients to set a goal of weight management, we have a plan. You just have to refer them to us. Thank you.
Thank you, Roshan. So this is just, it's so practical. What has happened to this child is there for everyone to see. And we go on to Prashant again. We'll just tell us how another case study and how it has worked with us. Prashant.
My slides are visible?
Visible, very visible. Go on.
Okay. So I'll be discussing about one of our success stories, and it is important to discuss these stories because it inspires us to do well in future. So I'll be sharing one of the patients who has undergone the comprehensive package. So she was 7.5-year-old girl, SL. She complains of excessive weight gain since last couple of years. On inquiry, there was a history of dyspnea on exertion, Also, she complains of mild snoring due to inadequate sleep. When we asked for the family history, there was no family history of obesity as such, but there was a family history of hypertension in grandfather. Also, there was no history of hypothyroidism in any of the parents. Parents were not so obese. Neither there was a history of any prolonged medications like steroid. On examination, her weight was 34.6 kg with height of 122.2 centimeter. So the BMI was around 23.24, which is obviously more than 27th adult equivalent, crossing the red line. So she was obese. To define the central obesity, we have calculated her waist circumference. It was 72 centimeters, which is obviously more than what is expected of 90th percentile. Her blood pressure was okay. On examination, she has acanthosis nigricans. She was pre-pubertal. There was no obvious goiter or any other malformation like polydactyly or anything. And her intelligent and developmental was absolutely normal. So taking the waist circumference is important because it is the independent marker of central obesity, and central obesity as per the literature, it correlates pretty well with the future cardiovascular or the metabolic risk and related complications like diabetes mellitus and hypertension at later age. So coming back to the diet, her diet was just as usual, kids food. She was breastfed exclusively and bottle fed up to 2 years of age. On inquiry, she prefers biscuit, precisely the cream biscuits and chocolates. She has a habit of binge eating. At times, she used to skip the meal. She likes breakfast. She likes fried and junk food without any physical activity whatsoever. And on inquiry, the electronic screen time was approximately 5 to 6 hours per day. And this was before the COVID happened, before the lockdown. So this was definitely much more than the obvious recommendation, as sir has discussed, that it should not, your non-academic electronic screen time should not go beyond 2 hours. So on all fronts, this was a lifestyle related problem. So she was tall and obese, fitting the bill of nutritional obesity. When we plotted her, you can see her weight chart. On the weight percentile, she was more than 97 percentile, and her height was okay at around 50th percentile. On BMI growth chart, she was way above than the 27th adult equivalent. So she's obese. On investigation, when she came to us, she had dyslipidemia with the triglycerides of more than 280. Cholesterol was 170. Her sugar was 81. Her thyroid functions were normal with just a marginal increment of TSH, that is 6.63. So we do see those referrals as an endocrinologist with this high TSH, but you have to consider that this TSH is more or less normal. It is just a thyroid hormone resistance because of the leptin, and it does not need a treatment with thyroxine. This is not a hypothyroidism. It is body's attempt to increase the metabolism rather. She had insulin resistance. Her fasting insulin was 24.9. Normally, we consider 10 as in cutoff in fasting state. Her HbA1c was around 6.1. So the diagnosis was nutritional obesity with hyperlipidemia with insulin resistance. She has enrolled in comprehensive package. After intervention for 12 weeks, her weight has gone down by 2 kg. You can see in December 2019, when she came to us, she was 34.6 kg with height of 122 centimeter. After intervention and bi-weekly follow-up, after 12 weeks, she has reduced 2.5 kg, and her height, there was height gain of approximately 1 centimeter. So there was a BMI reduction of almost 2 points, and even her marker of central obesity, that is waist circumference, has gone down significantly by approximately 2.5 to 3 centimeters. So this was a success which we got with the comprehensive package. So during the history taking, we should not forget to ask for these 4 things: the electronic screen time, the dietary history, dietary recall, as Dr. Roshan has said, the physical activity, and importantly, the activity, the quality and quantity of sleep. These 4 things you should definitely ask. Whenever there's a family history of blood pressure, diabetes, dyslipidemia, history of bariatric surgery or obesity, fatty liver disease, or early cardiovascular death before 50 years, then these are the alarming signs and one should refer these individuals. Please remember, if one of the parent of your child is obese, then his children is likely twice as likely to become obese. And what we see in more than 50% of obese children, we have one parent with obese. So whenever we are treating a child, we also treat the family as well. We do have Indian norms for the waist circumference. These are routinely available. All we need to see is whether the waist circumference is going beyond the 90th percentile. So whenever it is going beyond 90th percentile, you should screen them for the complications related to metabolic obesity and metabolic syndrome. So I'm just sharing this case. This was not a part of comprehensive package, but just an eye opener to sensitize that what all cases and complications we are actually seeing. So this was 9.5-year-old boy with weight of 80 kg and height of 131, came for just routine assessment of obesity. All we did is we ordered those investigations for routine screening, and we get a frantic call from the lab. There's a sugar which has been tested twice. It's showing 930 milligram per deciliter. Remember, the child did not have any symptoms whatsoever. He came walking to the clinic, but had to get admitted to control his sugars. See, his triglyceride, because of high sugars, his triglyceride has gone up to more than 1000. His HbA1c was 13. And to admit him, had to start on insulin. However, the workup for type 1, that is C-peptide, was absolutely normal. In fact, increased, and anti-GAD antibodies for type 1, they were negative. So this was a prototype case of type 2 diabetes mellitus with hyperosmolar hypoglycemic state. And we had a tough time. We had to start them on insulin because there's hardly any data of treating HHS in pediatric age group. So initially we maintained him on a regular insulin, followed by we have kept him on the long-acting insulin Lantus and oral hypoglycemic agent like metformin. After 4 to 6 months of lifestyle modification, he is off metformin. He has lost almost 12.5 kg in next 6 months. And currently he just follow a simple diet and lifestyle modification. So this is important to know that what complications of obesity can present to you even at this age. And this is going to be the future because of the, as Sir has said, that with increasing disposable income at the family, you will see more and more such cases of type 2 in future. So as we have previously discussed, the prevention is far more important, and it should not get restricted to particular child, but it should spread to school, the family, and the community. And the focus should be to prevent the adiposity rebound, and the prevention should focus a child, especially before 6 or 7 years of age. And the management is obviously the lifestyle modification, a bit of pharmacotherapy, the psychosocial support is required. And if all this fails and child has completed his adolescent the puberty, then only these children can subject to a bariatric surgery. Bariatric surgery is not an option for a child who is less than 15 years old, or he has not underwent into a normal puberty. So pharmacotherapy is not first line of treatment. There are hardly any drugs at our disposal, and they can be discontinued if there is no reduction in BMI score even after 3 weeks of medication and intensive lifestyle modification. So the drugs will also act only when the lifestyle modification continues. And what are the drugs which is available? Orlistat is the only drug which is available, and it is FDA approved medication, but given in children who is more than 12 years. It basically inhibits fat absorption, and it can decrease your BMI by almost 1 to 2 kilogram per meter square. Other drug which is often used off-label, not approved by FDA, is metformin. You can give metformin to prevent insulin resistance. It acts as an insulin sensitizer and can be given in cases of type 2 diabetes or any adolescent female which has signs of PCOS and insulin resistance. The dose is approximately 500 milligram BD after food. The leptin is used in specific genetic conditions like leptin deficiency, unfortunately not available in India. It is given in subcutaneous way by the injections. So just to summarize the approach of obesity, whenever you are seeing a child whose body mass index is going beyond 23rd adult equivalent, that means crossing orange line, you have to take detailed history and examination. If tall and obese, it fits into nutritional obesity. If your child is short and obese, then probably you're looking at endocrine obesity. You have to treat and investigate for hypercortisolism or hypothyroidism. If your obese child is associated with developmental delay or there is hyperphagia, then probably you're looking at a syndromic or a genetic obesity. If your obesity is associated with CNS symptoms like headache and vomiting, probably you're looking at a mass. In that case, you have to ask for the MRI brain. So in all scenarios, you have to work on lifestyle of the child and address comorbidities if at all they are present. You have to give adequate time for the lifestyle modification to act. In most of the cases, it's generally 3 or 6 months. But if you don't see any effect after 6 months, you may consider giving a pharmacotherapy. If everything fails and your child has completed a pediatric surgery as a last option. So at SRCC, we have these packages, a nutrition package along with comprehensive package or fitness profile. So you can enroll your patient into any of these. Nutrition package is associated with, is run by a dietitian. Precisely, comprehensive package involves a pediatrician, the endocrinologist, as well as the dietitian. So to summarize, our focus should be on prevention of obesity and related complications. As an Asian, we have high propensity to develop obesity and metabolic syndrome. The metabolic syndrome and type 2 diabetes, we are seeing at much young and younger age. And the last but not the least, the pharmacotherapy is not the first modality of choice, and pediatric surgery should not be an option to a childhood obesity. So key to the treatment is motivation, lifestyle modification, and again, motivation. So unfortunately, there are hardly any takers for lifestyle change. People want a shortcut like pills and surgery, but unfortunately, it doesn't work. So to prevent a modern childhood obesity epidemic in our generation X, and we have to work them so that they don't get converted into XXL generation. So thank you so much for your patience.
Thank you, Prashant, for that. We've come to an end of a very long day. I thank all the people who are watching and participating for their attention. I only want to say that we had a malignancy kind of talk in the beginning, then the spina bifida, and now this obesity. But the obesity is far more common, far more rampant, and every doctor who's viewing us just now sees obesity. Please, please, please take it seriously. Do something about it, because we have, going into a generation who is going to live less than the previous generation. So the life expectancy of this generation for the first time has gone down as compared to the previous generation. That is terrible. And that's what the future holds for them if we are not careful. Thank you. Thank you very much for a very kind attention that you paid. Thank you.
Thank you so much, sir. And thank you everyone for this wonderful masterclass and great session on multidisciplinary care and wonderful talks on 3 important topics. And as sir also recently said, that obesity and other such issues are a big concern. So hope everyone has taken the messages from our specialists, and hopefully this will help you in taking care of your patients. Thank you so much everyone for attending this webinar, and we will get back to you soon regarding next month's session. I'd like to thank everyone at SRCC and all the members of various teams who are doing such an amazing job at SRCC. I'd also like to thank Dr. Rasiksha and Dr. Sonu Dani, who are the main people who have initiated this masterclass session. And thank you everyone again for being with us, and we will see you again soon with more and interesting topics as usual. Thank you so much.
Thank you.